Welcome, everyone, to the New Year's Eve event for the World Health Network. This is one of our biggest events of the year, and we're so glad everyone is able to join us today. We have fun programming. We have programming for kids, for families, and as well as scientific speaker sessions. We're going to have data science sessions. We're going to have long COVID sessions, and we're going to be hearing from some of our um, leaders here, Frank Lancero with the relations team and the community action. And we're going to have some welcome sessions with Sharon. So it's going to be lots of fun. We've got Joe Eastman here and Vincent on the science data end. We're going to be doing updates for science updates in a little while, and we're also going to have trivia and some games. If I could have those co-hosts allow some of those videos to come through after we've confirmed identities, basically. We just wanted to have a very smooth event today, so bear with us while we go ahead and do that. So we will be allowing folks to turn their video on one by one. Thank you so much. Yeah, so I'm going to go ahead and turn it over to Ynir so he can welcome us, and then we will move into our first session with Danielle Beckman. Oh no, with Shvela, and then we'll be hearing from Danielle Beckman and Satish Raj a little bit later. Thank you. All right, Ynir, turn it over to you.
So, Happy New Year, everyone, and welcome and thank you for joining tonight. Or it's not really tonight yet, but it's great that so many people are gathered to close out this year and start the next. I want to say a few words about the past year. It marked, for me, a real turning point. We moved from pushing back against deeply hurtful guidance, including policies coming out of HICPAC. If you remember them, they don't exist anymore, to actively supporting a major shift towards prevention in healthcare. We had very important leadership from the Canadian Standards Association and the UK WHS, and we helped galvanize a broader global move towards respirators with thousands of signatures calling for safety in healthcare. And those changes are now visible. Just yesterday, we heard from Frank, actually, that when a hospital in New Jersey reintroduced masking requirements, we learned that most of the staff were wearing N95s. And this is a major shift. And a year ago, many people were feeling isolated. This year, apparently, we're all one of the two. So as we look ahead to the coming year, there is a lot happening in the world, and there is much work to be done. But this year showed clearly that building for the future is possible. At WHN, the work is continuing to expand. We now have over 40 active teams working across science, communication, community action, technology, and growth. There are many ways to engage through projects, collaboration, or a growing range of ongoing social activities, and I hope many of you will consider participating. For those of you who want to extend this constructive approach beyond public health, I also want to invite you to the On Politics meeting in February. It's an opportunity to bring the same solution-focused spirit to other domains where thoughtful, coordinated action is urgently needed. However you choose to engage, or even if this meeting today is simply a moment to be together and mark the transition, thank you for being part of the community. Together, we are building toward the future. Thanks again, and best wishes for the new year.
Thank you so much, Ynir. All right. Well, I'm excited to announce our first speaker, Shpela Salmon, will be. Can we remove the spotlight?
So thanks everyone for showing up. This is not going to be a very long lecture. It's meant more as a Q&A session. So I'm just going to quickly go over Like, I don't know how many of you have already read the paper that we're talking about. So feel free to write in the chat if you've read it or if you know which paper it is. I mean, its title is on the screen right now, right under the main title. So yeah, um, and the picture I put on the first slide, I put it there for a reason. I think a lot of you are probably familiar with this picture or with the WHO like influenza monitoring system. And what we can see in this graph is that in the time when we had a bunch of precautions, there was practically no flu. And every year since then, the amount of flu that we have had and the peaks and everything have been increasing. And uh, this has to do with the topic of this talk. Spoiler alert. Yeah. So, oops. So first, I'm going to very quickly introduce myself because maybe not all of you already know me, some of you do, but I'm a board certified nuclear medicine doctor, and my day job is performing mostly stagings and diagnostics of advanced cancer and other very, severe and difficult diseases with unknown origins. I included a few pictures so you can see what kind of things I am looking at. What you're looking at basically is the glucose metabolism in the body, and everything that is black, or in this case, bright orange, is unfortunately cancer. So, yeah, I have a lot of very interesting pictures to look at work. But at the same time, I'm also a scientist, I'm a geneticist. I did a PhD in complex degenerative disease genetics, and someone might say, well, those are two completely unrelated things, but I disagree. Those are very related because disease happens from the atom to the body on all levels. And my goal with this interdisciplinary education is to basically be like kind of a little bit of a disease detective to try and understand what's going on with sick people and to also study these diseases from the pathophysiology standpoint. I'm also, of course, active in several societies, including the WHN and other places where I fight for better public health and like precautions in healthcare and all the good stuff. So comparisons of COVID-19 or its virus SARS-CoV-2 to other diseases have been made a lot. And very often these comparisons are not really the right ones because we often hear comparisons to the flu, to common colds, to other quote unquote harmless viruses, which we know are not harmless, but mostly cause an acute self-limiting disease with sometimes chronic consequences, but not always, right? And diseases that are actually comparable, maybe in some way, in terms of ongoing disease, ongoing harm, are other diseases other infectious diseases that can cause chronic disease. They are named here. I'm not going to read them all out, but these are things that can infect you and then they can either stick around or they can trigger a sort of chronic disease of some type. And very importantly, many of these diseases begin a lot like the flu. So, even when you catch HIV for the first time, for example, most people are sick for a week. They feel a little tired, under the weather, maybe they get a little bit of fever, sore throat, or whatever, and then they feel fine for years, right? So, it's important for us to compare things that are similar to each other and not things that are completely dissimilar. And why did we decide to compare SARS-CoV-2 exactly to HIV and not any of those other things that I named? Well, there was this hashtag airborne AIDS, that began spreading on the internet and in patient groups. And because we pay attention and we keep current with what patients are talking about, we picked this up and we wondered, why are patients describing their issues this way? And might there be some kind of background, right? And we have come across several other comparisons. They have been made. Many papers have been published with this comparison, so we're not the first. But some of them were a little bit outdated, maybe from 2020 or 21. Others were just comparing one aspect, and we said we want to make a full comparison so that people, first of all, can orient themselves. Is it really AIDS, right? And the other part is that we bring this into a very sober scientific perspective. So, is there a reason behind this comparison? Of course, this is a very sensitive topic, and with this paper, we never meant to, trigger anyone. We never meant to leverage anyone's stigma or anything like that. So our goal was to help everyone from stop from to help everyone to prevent them from repeating the same mistakes that we made already in the AIDS pandemic, and so that we can learn from the AIDS pandemic and apply the lessons to this new pandemic. So the comparison is quite long and technical, and we don't have the time to get into the meat and potatoes of everything. But the important aspects we will go through one by one. And this is a little graphical abstract that you can look at later as well to see what these shared outcomes are, what the shared traits of both pandemics are, and how to compare basically these two things. Of course, the transmission is different. So HIV is a blood-borne virus. It is mostly sexually transmitted. It's also transmitted through blood products from child to mother, so vertical transmission. And it's an RNA retrovirus that integrates into our DNA. So we can say persistence is kind of built in, right, into its pathology. With SARS-CoV-2, we have a different mode of transmission. Of course, it transfers through the air from aerosols, very tiny droplets, to bigger droplets, fomite transmission. So by contact, it is possible, but it is very, very unlikely. It's an RNA coronavirus. And as far as we know, it does not really integrate into DNA. It can damage the DNA, but it doesn't really insert itself into it, as far as we can tell. But the virus itself or its fragments can remain in various tissues for a long time and cause a lot of problems. So there are a lot of similarities and differences in terms of immune impact. Again, I'm not going to go too deep into this, but the similar things that are important to understand is that it causes mostly depletion and exhaustion of immune cells, including but not limited to T cells. And this mostly happens through a state of chronic inflammation. So you can imagine the immune system stays busy with this inflammation, and that means it cannot process other infections or other things as efficiently. Sometimes it can get overstimulated and it can cause autoimmune reactions and stuff like that. The common thing that happens in both is also neurodegeneration, so brain damage, and kind of forms of premature dementia and other neurological problems. We have the term, the HAND is HIV-associated neurocognitive disorders, and then we have SAND, like the SARS-CoV-2 related, and so on. Other than opportunistic infections, this means infections that take advantage of this immune dysfunction, this can happen without any apparent symptoms. And the same thing is true for HIV. People are symptom-free for years before something starts happening, usually. But there are also a lot of differences. This is not the same disease, and that's very important to understand. So HIV is very focused on this one type of T cell, and it slowly over time erodes and depletes and destroys these cells. And almost always this results in a progressive collapse of the immune system, even after just one infection with HIV, right? This all takes 10 years or even sometimes more. And with SARS-CoV-2, this is completely different. It's much broader, so it affects more parts of the immune system. It's much faster, so it happens in a few weeks rather than in years. But there is some opportunity for recovery over months, sometimes over years. But this requires most likely that there are no reinfections. So reinfections most likely will make it very hard for a lot of people to recover their immune function to the healthy levels. Another very important difference is for HIV. We have medications that make the quality of life quite good. Yeah, not perfect, but great. With SARS-CoV-2, we have practically nothing. And the patients that suffer from severe long COVID, they have a quality of life comparable to stage 4 cancer. So in terms of therapy, it's kind of better to have HIV these days. I mean, it's not good to have either, but in terms of therapy, we are much better equipped to deal with HIV. Some HIV drugs are being trialed. Maravirok and Truvada are being trialed by PolyBio right now for long COVID. So another parallel. And the result of this immune dysfunction is very visible. We have a lot of mainly opportunistic infections that have spiked crazily, right? Since I know this is a little bit hard to see, but like about in the middle of this graph, you can imagine here's 2015 and here is 2020. And so, everything is skyrocketing, right? So that's just the population level effect. People are affected very differently. Some people might not have any kind of immune dysfunction after infection. Others have a very severe immune dysfunction. Most are somewhere in between. But on a population level, this manifests as increased spread of other diseases. So it's not immune debt or whatever, it is immune damage. So these are the different ways that these two viruses affect the immune system. So as we said, integration into DNA with HIV, and then this progressive attack on the CD4 cells. And this results in opportunistic infections, systemic sequelae, and the neurocognitive disorders. With SARS-CoV-2, the mechanisms are very different. There's a very big component of the microvascular issues, so the blood vessel damage, basically, which makes all the membranes too permeable. This constantly irritates the immune system, the blood-brain barrier, the gut-blood barrier, all the barriers are broken down, and this causes constant poisoning of your system with things that are not supposed to be in your blood, right? Just to be simple about it. And of course, the endothelia, the inner linings of your blood vessels, are chronically inflamed, and this is all causing, poor circulation. Immune system cells cannot get to where they're needed, and so on. So it's very complex. There's a lot of gene reprogramming and all kinds of crazy stuff. But the final results are not all that different. So we have opportunistic infections, systemic sequelae, and neurocognitive disorders. Chronic infection or viral persistence is still a little bit controversial. We know it happens in some people, but the question is in how many. We have different detection methods, and these different detection methods give us wildly different results. So a lot of this resistance could be hidden away in certain types of cells, which are hard to reach. So, you have a living person, you cannot exactly stick a needle or whatever into each and every single one of their organs to find the virus. So it's a little bit hard to do in practice. And this is why sometimes persistence is tricky to detect. And so we don't know exactly how many of the people who get infected with SARS-CoV-2 have this persistence. Some studies say about a fourth. Other studies claim up to 60%, and there's some very sensitive methods that even claim things like 70, 80%. This is all very different. So what we can say is that most likely with repeated infections, the risk that the virus gets a chance to settle somewhere permanently is probably going to go up, right? Because it gets more chances to do it. So I'm not going to talk about treatment for a very long time. So we have the antiretroviral therapy that is also currently being trialed against COVID. We have PrEP, which is a kind of therapy you can take as a prophylactic, so as a prevention. For COVID, we have vaccines, which we know that are not perfect, but they help. For HIV, we currently don't have vaccines yet, but they are being made, and hopefully they will be out soon. This highlights the similarity, but also maybe offers a chance that some people with long COVID, especially those who do have active viral persistence or those who have um, like other viral reservoirs like Epstein-Barr virus, cytomegalovirus, and other viruses that can be activated through COVID infection. Maybe these people can benefit from this therapy. We will just have to see what results the trials provide. I think socio-political parallels are very important. I'm not a social scientist. I had other co-authors that handled this part of the paper, but I personally thought it was very important, and this made the paper a lot harder to publish because we were thinking, these biomedical papers, they don't want us to talk about politics and society. But I think it's very important, and I insisted that we had to find a journal, and we did find a journal that would publish the paper in its entirety with the socio-political part. Because I think the main message of this paper has to do with exactly that. So it has to do with our successes and failures in the AIDS pandemic, and how a lot of the same mistakes that were repeated, claiming the disease is psychosomatic and stigmatizing people and discrimination and the failure to protect vulnerable groups, marginalized groups, global inequities, all of these things. They have been a very major driver in both of these pandemics. And interestingly, the airborne transmission makes COVID-19 a much more universal threat, but because it affects everyone like this and not some particular group so much more than the others in the beginning of the AIDS pandemic, we are lacking like a very central community-driven advocacy, like they did, like the AIDS patients. Basically, they were the ones who pushed to have the disease recognized, and I think they had a much stronger community than we have around COVID, and that is also something that needs to be learned and needs to be applied. So we all know the consequences of ongoing COVID spread. I'm not going to preach to the choir too much. So we know that the reinfection increases all kinds of cumulative risks, including long COVID symptoms and also all kinds of other diseases. It means complications of COVID, like heart attack, embolism, premature dementia, opportunistic infections, organ failure, and all of these things. So we all understand probably in this room that lasting natural immunity is impossible with a virus that is always evading our immune system, that is learning how to suppress our immune system, how to dysregulate our immune system, and we are just not going to out-evolve a virus. That is not going to happen. So without mitigations, this will just lead to increasing amounts of disability and chronic illness and healthcare system collapse. And this is especially true since Omicron. I have been quite controversial for claiming that Omicron or post-Omicron variants are more dangerous than previous variants. And I don't mean more dangerous in terms of acute disease, I mean more dangerous on the long term, because what they have evolved is an increasing capacity to reinfect us. And we all know that the number of reinfections is the biggest risk factor in terms of long-term consequences. So a virus that can infect you more times in a shorter period of time is simply more dangerous on the long term. And even if the uh, individual acute disease is maybe not even noticeable or very, very mild. I had another paper called From Crisis to Solution. You can find it on the WHN website, but I just wanted to show this duality of rising symptoms, rising risks. So it all beautifully aligns, right? The With each infection, the risk for long COVID symptoms goes up. It's almost linear. Different studies show us a little bit different curves, but that doesn't matter. It's cumulative. Some show us maybe the next infections add a little bit less risk, but it doesn't matter because with enough infections, everyone or most people will eventually end up somewhere close to 100%, right? And the same thing doesn't just happen with symptoms, it happens with risks that are often not associated in our healthcare systems with COVID. Like they don't connect the dots. But we can see from studies, from massive studies, that the risks of every single health problem, hospitalization, cardiovascular disease, blood disorders, pulmonary disease, diabetes, like everything goes up and it's just perfectly linear or it just keeps going up. So it's additive, it's cumulative, and that's what's important. Symptoms and disease are both going up because those are often not the same thing. So uh, I'm not going to be very, very long about all of these consequences you can imagine. But what worries me the most actually is these final two. So uninformed clinical care, including exposure to unsafe conditions in healthcare setting. This is a great, how should I say it? It's medical malpractice. It's a crime, and it needs to be changed. And that other thing is the influence on brain function. And this can also be a little bit controversial. I have been called ableist before for saying, it shrinks your brain, it makes you aggressive, but it does, right? And so things like intergroup violence, traffic safety, addictive behavior, quality of our work, specialist work, medical work, scientific advancement, all of these things are under threat because our brains are shrinking with each reinfection, right? And this is something because this can rob us of the one thing that can help us solve this problem. So you see, this is a very big issue, and I have other talks on this topic, but let's continue because we don't have much time, and we are almost through. So I always emphasize the role and responsibility of healthcare workers, professionals, institutions, societies. So it's, yeah, we can discuss afterwards, but I think it's such a big deal that doctors and nurses and other healthcare professionals understand this and also practice what we preach. So today I'm not wearing a mask because I'm alone at home, so I don't have to. But at work, you will never see me maskless, and you will always see me monitoring the air and making sure everyone is safe as they can be in a hospital because hospitals are unsafe even if you try them to make them safe. So I think this is very important. And it's a big task ahead of us, and it will probably take the rest of my career, but I will try to push for this and see where it takes us. So I would like to kind of segue into the discussion with these unresolved questions. So things we really need from my perspective. are biomarkers, so biomarkers for viral persistence, but also, for example, for naivety, because we don't have a test right now that could confirm someone to be a so-called novid, so someone who hasn't been infected, and we urgently need contemporary controls. We cannot perform, like risk analysis and stuff if we don't know what the healthy control group is. And the healthy control group cannot be people who have also had COVID. I mean, you can do a study between people who have been infected once and people who have been infected 5 times, but first of all, it's not perfect. And second of all, you need a marker that will tell you how many times people have had it because no one is PCR testing like 3 times a week for the past 5 years. So they cannot possibly know exactly how many infections they had. We also need effective antiviral treatments for chronic infection, for chronic inflammation. And research is underway, but unfortunately, still way too much money goes into various ineffective strategies. I'm not saying physical therapy is completely ineffective, but it's not going to cure you, right? And for example, graded exercise therapy can even make you worse. So there's things that should be studied more and things that should not be pushed as much. Then we have broadening the understanding of cumulative impacts of reinfections, especially among healthcare professionals. Absolutely, we need better strategies for airborne prevention, and we need to do more for infrastructure of surveillance, isolation, quarantine, and so on. It can all be done. It's not hard. It just has to be done. And just like with HIV, prevention is still the best. We have medications against HIV, but do you want to catch it? You don't want to catch it, right? So you use a condom, right? You test the blood before you give it. And similarly with SARS-CoV-2, even if we manage to get medications in a few years, it will still be better if you don't catch it, right? So prevention is absolutely key, but especially as long as we don't have a cure, prevention is even more important. So there's that. And I want to thank you for your patience. And our house doesn't seem to be on fire, so if you want, you can ask me some questions now. I'm looking through the chat. I haven't had the option to look through the chat because I've been focusing on talking.
Yeah, let me see if there's any. There was one question I can elevate for you, Spela.
Okay.
Evan Sachs was wondering if you would be a good contact person or if you would know where to send people that think they may have never had COVID and would be interested in an experiment. Do you know of any one gathering those names or would you
Mhm.
take them?
Very good question.
Yeah,
I
thank you.
I have been actually pushing for this very initiative before. I have talked about it to my friends at the Long COVID advisory team. Like, hi, if any of you are around here.
Yeah.
Um, so yeah, I think that would be a great initiative, and I think something like that could be done maybe even by
Mhm.
the WHN to collect, of course, personal data protection and stuff. It's always an issue, right? But I'm sure this could be done in a smart way because I think currently, right, like at this point in time, we don't have biomarkers, but we have these people who are crazy COVID competent, right? We have people who have been masking, testing, HEPA filtering, walking around with RNA fear for everywhere, right? And these people are by far the most likely to be actually uninfected, right? Because there's a lot of people in the public who claim they've never had COVID. But I don't think so. Like, if you have not been taking precautions for these past 6 years, I think the chances that you really are naive are really low. I mean, there are going to be some people. There's always, with every disease, there's going to be some people who are just simply naturally resistant to it. It's the same with HIV, incidentally, right? And so there are a few of those, and it's important to study those as well, because those can hold some biochemical and biological keys to solving the disease itself. But right now we don't have naivety markers. So what's important is, I think would be great to have some kind of base or some kind of source where us scientists, when we need to find a healthy control group, can go and we can be like, yeah, so this, and this person, they think they've never had COVID. They have been taking precautions since 2020. They have been tested several times, never tested positive. Maybe they even did like nucleocapsid. Like I personally have done that. Like I have taken maybe once a year or so a nucleocapsid test just to see maybe if something went under the radar. And so far, all of them have been negative. I don't know who to thank, maybe my mask. But either way, I think that's a great question and a great initiative. And I sadly don't know of anyone who is already doing
Yeah.
this, but this just means we probably should do it.
Okay. Thank you, Spela. Um, I just want to get one more question in before we switch over. We're going to be hearing from um, Caitlin, and she's going to give us some science and research study updates. But this is such an important topic, like you said, to gather people that have not, had COVID,
Yeah,
and we will assist in that. So anyone who would like to participate in
I
that way,
volunteer.
like to continue, yeah, I would like to continue the conversation in any way, shape, or form. Like if you would qualify, or if you know someone who would qualify, or you're just interested in that project, please email me at katie@nexi.edu. And a little bit later in the program, we're going to be sharing with you a follow-up form. So if anyone wants to stay in touch with WHN, has any follow-up requests, we will have a form for that coming in the chat shortly. But I see Greta had a question here for you, Shpela. Let me go back.
Uh-huh.
Greta, if you want to come on, and we know Greta. Greta's part of our COVID action group, and um, Greta is a nurse, and we're really grateful for your participation, Greta. If you're there, I can read your question, or you can read it.
Yep, great presentation, Shpela. I was just asking what we know about the current state of the research into the biomarkers. I don't know if that's what
Mhm.
Akiko is working on at Yale,
Mhm.
but what do we know about that progress?
Well, that's a very big topic. I don't know. I don't think we have the time to get into it. I think we would have to have a whole new presentation or a whole new talk
Yeah.
on that topic. And I also have to say, maybe someone else could even be a better person to talk about that than me, because while of course I'm interested in this, I have not. This is not like exactly the thing I have been directly so studying so much recently. But in biomarkers in terms of long COVID, you mean, or in terms
Yep.
of infection, or what?
Both. You're right. It's a big topic, and
Yeah,
maybe we just figured out the focus of our
yeah.
next conference.
It's a big topic. It's a very big topic.
Yeah.
Like I think the most, like I mentioned, the most useful in for most people if they want to check their status is the nucleocapsid antibodies. I don't know if I'm pronouncing that correctly, but they
Yes.
are the N antibodies, not the S antibodies, and they show you that you are whether you had an actual infection. So if you have the viral nucleus proteins and not just the spike proteins, which you can also get with the vaccine, right? So it differentiates between infection and vaccination, and it shows you if you are if you have been infected. But unfortunately, they are not super like they are very specific, but they're not very sensitive. So you can, if it's been a few months from your infection, or if you have had a lot of vaccine doses and you dealt with the infection very quickly, then you might not have these antibodies in the first place, and then in a few months they normally disappear. So if you wanted to really be sure, you would have to do this test, like, I don't know, 4 times a year, and you could still not be completely sure,
Yeah.
because um, How would you ask your healthcare provider to, well, right? Well, I don't know. Like it's very much depends on where you are. I don't know. Like I had to pay for mine. I'm a doctor and I couldn't
Yeah.
prescribe that to myself. I had to pay for it. So it very much depends on your where you are. Maybe your family doctor can help you. Maybe you have to go to a private lab somewhere. I really cannot tell you because I haven't even said I am in Austria. I am in Europe. So it
Yeah.
very much depends on where you are.
Yeah.
But as far as I can tell you, it's called N or nucleocapsid protein, and that's something you can check for infection status or like past infection. But don't be like if it's positive,
It's not
then
that
you had
reliable.
it.
Yeah.
Then you can be
Yeah.
pretty sure you
Yeah.
had it. But if it's negative, well, maybe
Well,
not, but also maybe you had it. And if you
mhm.
did, it's likely that you got rid of it fast
Hmm.
enough that it didn't really affect you so much. So it's still a very
Thank
good
you.
kind of
Yeah.
measure of whether you might be
Yeah.
affected. So for people with long COVID, I would definitely do one because it will also maybe show up if you have viral persistence, possibly. We don't really know, but it's more likely.
Well, it ain't hepatitis B. It's not going to be simple. Thank you, Spilla.
Yeah, unfortunately.
Thank
This is a
you.
very
Thank you so
evolving
much.
topic. Yes.
Thank you. Yeah. Um, Thank you so much, Spela. This is such a fascinating and scary also topic. But
There's
I'm
too
really,
much to talk
yeah,
about.
it's a lot. It's a lot. But we have Caitlin up next. Caitlin, would you like to come on and then I can elevate you as speaker?
Sounds great. Hi, everyone. My name is Caitlin. I'm currently the head of the science content team, and I recently finished a PhD in bioengineering. So while this isn't COVID and infectious disease in general isn't my specific area of expertise, it is, and as with everyone here, a topic that I care about a lot. So I prepared a brief presentation just about some good, mostly good science news from the year, and also discussing like where I find this kind of news because especially with everything going on, it's really easy to lose hope. And um, I, when that happens to me, I find myself really turning to science and what people are actively working on that could help make our world better. So, yeah, some good science news. Vaccine research is continuing. Um, Although, unfortunately, we've had a lot of setbacks this year. Grants studying vaccine hesitancy and mRNA vaccines were both cut by the Trump administration. And RFK Jr. replaced the Advisory Committee on Immunization Practices, which has led to weak and non-evidence-based vaccine recommendations coming from the US government. However, research for better vaccines is ongoing globally, including some in the US still. There are a couple types of next generation COVID vaccines that are in development. Long-lasting vaccines use self-amplifying mRNA. So that's similar to the existing mRNA vaccines, but the mRNA is able to last longer in the body and to produce more copies of itself, which means that for a longer period of time, the spike proteins and the immune response is being generated, which can lead to longer lasting protection. There's one self-amplifying mRNA vaccine that's currently in use in Japan and the EU. Pan-coronavirus vaccines are aiming to protect against all variants of COVID or even all coronaviruses. And mucosal vaccines provide protection in the tissues where COVID-19 infections begin, such as the nasal linings, and they can offer stronger protection against infection and transmission. And that's really the big difference from our existing vaccines, which largely protect against severe disease. And there are mucosal vaccines currently authorized in Iran, Russia, China, Morocco, Indonesia, and India. There have been a number of studies looking at transmission in animal models that have shown that these mucosal vaccines prevent, for example, like a hamster in one cage who's been infected with COVID-19 from infecting another in the cage next to it that share the same air, whereas unvaccinated hamsters might infect each other. So another depiction of this mucosal immunity idea is from a review article and depicts the mucosa as a sort of the walls around a castle, where having the strong mucosal immunity prevents the virus from entering our body, which prevents illness and therefore transmission. On the other hand, our traditional vaccines are more like this image on the right, where we have a much stronger defense inside the body, in the bloodstream and circulating, which helps prevent against severe disease, but won't stop the viruses or pathogens from getting in at all. Some really interesting sources I found for vaccine use and funding are Hilda Bastion's blog, Absolutely Maybe. She does a post at the end of every month about vaccine news. That's new clinical trials that are happening, any news on approvals for different vaccines, and even preprints or scientific studies that have been posted on new vaccines. MUSIC, the Mucosal Immunity in Coronavirus Challenge, is a European consortium that's working on human challenge trials. What they're doing is actually working on studies where they'll directly infect people with COVID after treatment with the vaccine. And of course, with studies like this, there has to be a lot of care taken with the safety of the participants to minimize long-term risks. But these challenges can also facilitate much quicker development of vaccines because you're able to directly compare like a group of people with vaccine A versus a group of people with vaccine B and how many of them are getting sick or transmitting to others. And finally, CIDRAP at the University of Minnesota and CEPI, the Coalition for Epidemic Preparedness Innovation, run the Coronavirus Vaccines R&D Roadmap Initiative, and that includes a database of vaccines in development. This one, I think only, or at least was revamped in October, so pretty recent. And I can drop a link to all three of these in the chat after I'm done speaking. Long COVID research is another area where there's a lot of progress. The research is largely focusing on uncovering mechanisms of action. So how is COVID persisting in the body? Where is it persisting in the body? And also potential treatments. So despite challenges from NIH funding. So this source that I really like for long COVID research is the Polybio Research Foundation. They hold symposia twice a year covering their long COVID research from all of their scientists across many different institutes. And a lot of the work they're doing is identifying and characterizing biopersistence. So where is the virus sticking around in the body, through what mechanisms, in what forms. What they've shown so far is that there's a lot of, there are a lot of different ideas and a lot of different locations where virus could be persisting, and it could be different for different people. So it's a complicated topic that they're actively working on. Related is detecting biomarkers and classifying types of long COVID in order to better be able to identify patients with long COVID, or if we can break down subtypes of long COVID, that may help identify what treatments are appropriate for which groups. And of course, they're also working on clinical trials of drugs and drug combinations for long COVID, including at least one where an existing cancer drug is being applied to long COVID. And finally, ARPA-H Breathe is a program from, I believe that started last year, that is funding pathogen detection. So BREATHE stands for Building Resilient Environments for Air and Total Health. And this year, they awarded funding to 4 groups that have the goal of measuring indoor air quality in real time in order to implement interventions that will reduce the risk of airborne disease. So what that means is that they're developing different kinds of sensors that can detect airborne pathogens. So they might be able to tell if there's COVID in the air, bird flu in the air, regular flu, or even more rare and more hazardous diseases like measles. And as a result, the goal is to be able to trigger appropriate responses, including increased ventilation and filtration in buildings, or even in severe cases, an alert to leave the building. And what's particularly exciting to me is that these systems are planned to be tested in education and healthcare settings. So hopefully from these studies, we'll be able to see some real data that implementing sensors and improved air quality can result in decreased infections in particular settings and some of the most sensitive and important settings we have. So that's my brief overview of some science news from the year. And I'd also like to take a brief second to talk about what our science content team has been working on. We do newsletters on timely public health topics, which you've probably seen in your inboxes. We help edit and revise material from other WHN teams. And this year, we published 8 newsletters. One of the materials that we helped revise was the data visualization team's great work on long COVID stats. Please check that out if you haven't already. It's really cool. We started a clean air panel series in October, so please keep an eye out for more of those in the future. And we've also helped contribute to the Kids Zone magazine. So please feel free to join the Science Content Team channel on Slack or DM me, Caitlin Miyazaki, if you're interested in working with us. So yeah, I think that's all I've got. If anyone has questions about the topics that I covered, like I said, I'm not necessarily the expert on any one of these individual topics, but I like to keep up on science news.
Absolutely. Thank you so much. There were a couple of questions in the chat, but let's do a time check. Yeah, we have a few minutes. Let's see. I also wanted to note that I put some more information in the chat about our schedule today. And we also have a partner DJ playing on another Zoom. If you were interested in listening to music, that'll be going on until midnight in Europe. So if anyone's interested in that, I think Sharon can drop the link for that DJ.
Just did. I just dropped it
Perfect.
in the chat. I also dropped a link to the form for if anybody wants any more information about WHN or what we're doing or how to get involved. There's a
Mhm.
form now in the chat as well, so feel free to fill that out.
Okay. All right. Could one of the co-hosts put Femca into the kid zone, please? Thank you. All right. Did you
Will do.
catch any questions, Caitlin, that you might
Yeah, I
want
see
to
a
answer?
question about the technology behind broad spectrum vaccines. Like I said, I'm not an ex vaccine expert, but I've seen some papers that are looking at targeting different parts or more conserved parts of the COVID vaccine, or sorry, the COVID virus. So if you're targeting the spike protein is something that changes quickly. If you're able to target a part that doesn't change as much, the idea is that you'd be able to maintain coverage and immunity against COVID even as it mutates.
Thank you. All right. I'd like to talk. Is there any other questions before we move on that you wanted to answer, Caitlin?
I might have missed something, but I don't see anything else in the chat. So I think we should be good. Thanks everyone for
Okay. Well,
listening.
thank you so much. That was an awesome overview. Caitlin, can you put your contact information in the chat? Folks might want to follow up and participate in those activities. That would be awesome. I did just open the videos for our participants. Seems like everyone is familiar, so if you'd like to put your faces up, it would be great to see you. Um, and if anyone would like to go to the Kids Zone, I think we might have just had the Kids Zone account sign in, so if someone could route them over to the Kids Zone, that would be great. Just a reminder, we have trivia and games, an option. And we also have a family kids zone option where we're playing different games with kids, and those are in the breakout. So if you would like to go out of the main session and go into the kids zone or to go into the trivia and games area, just put a note in the chat and one of our co-hosts will move you into those alternate rooms. Um, As many of you know, my name is Katie Marsh, and I am one of the folks here that helps coordinate events and community activities and coordinates new teams. So if you're interested in joining the WHN or just following up after this event, or you have any questions, we have a follow-up form that I did drop into the chat here, and I will drop it again. It's our event follow-up form. You could also give us feedback on this event or requests for different types of events for the future. We do town halls. We have so many different um, options. So we really want to hear from you. So if you wouldn't mind filling out that form if you did come today, that would be fantastic. And then up next, we have an exciting presentation on POTS. We have Danielle Beckman, and let me introduce them. And if the co-host could go ahead and elevate Danielle Beckman and Satish Raj to get their video started, you can just add them as a co-host, or you can ask them to unmute um, and come on video. So Danielle Beckman and Satish Raj are going to be coming here to talk about POTS. Both Danielle and Satish are part of our WHN Long COVID Advisory Executive Group, and we will have a live Q&A after their presentation. Let me tell you a little bit about Danielle. Danielle is a neuroscientist interested in neurovirology and neurodegenerative diseases. She has a master's in biophysics and a PhD in biological chemistry. Currently, she is a project scientist at the California National Primate Research Center, coordinating the development of novel monkey models for neurological diseases such as Alzheimer's and neuro-COVID. Research interest in collaborations, high resolution microscopy, acute and chronic viral infections in the brain, Alzheimer's disease, and other neurodegenerative diseases, post-viral syndromes, and long COVID. A warm welcome to Danielle. We are so happy you were able to join us today. And with Danielle, we have Satish Raj. Thank you so much. Hi, Satish. Really glad you could make it. He is a heart rhythm cardiologist. He spent 12 years at the Vanderbilt Autonomic Dysfunction Center. After moving back to Calgary in 2014, he founded the Calgary Autonomic Investigation and Management Clinic. He is currently the director of education at the Limbin Cardiovascular Institute and professor of cardiac sciences at the University of Calgary's Cummings School of Medicine. He runs an active human autonomic physiology research program. Primary research interests relate to understanding and better treating postural orthostatic tachycardia syndrome, also known as POTS, vasovagal syncope, orthostatic hypotension, and initial orthostatic hypotension, and now long COVID. Welcome to both of you. So excited to have you come on and chat today. I will turn it over to you. Thank you.
Thank you. Satish, I think you're muted. There you go.
Sorry, for a while I couldn't actually unmute, so it's the way my family usually likes it. Uh, am I sharing or should I be sharing my screen or is it
I did make you co-host, so you should be able to share screen without any barriers. Thank
perfect?
you.
Let's get this going then. So first of all, thank you all for uh, joining me. Although quite frankly, the kids zone sounded good. I actually wasn't sure if I wanted to go there instead, but I probably should stay here for the hour anyway. So I was asked to give sort of an overview of long COVID POTS, and I think Danielle was going to be here to be the smart one to explain the parts I don't understand, and there are obviously lots of that. So we'll sort of get through sort of the basic content, if you will, and then there should be time for Q&A where Danielle can deal with the tougher stuff. My conflicts are shown here. I will leave this up for a moment for one reason only. There's actually nothing here that has to do with anything that I'm going to talk about, except that some data I'm presenting was collected with a small research grant from the Canadian Institute of Health Research dealing with long COVID. But all the POTS consulting here is intriguing because if I would have given a POTS talk 10 years ago, um, there was nothing, right? I mean, the truth is uh, it's still not enough to make me rich in any meaningful way. But the point is now there's actually interest in this from pharma, right? So
Satish,
Regeneron, yes.
sorry to interrupt you. Do you think you can make the screen bigger, like with the slides,
Oh,
because it's
not
showing
sure
small?
why it's
Maybe
doing this.
presentation mode,
It's in a
maybe?
presentation mode, yeah.
Uh,
I think if you click on the little icon next to CC on the there, maybe. Yep, there
Yes.
you go.
Perfect.
Yeah, I'm
Awesome.
still
Thank
seeing
you.
different things. Okay, sorry about that. I thought that was just on my view that it looked funny, but who knew? So the point is actually that there's actually companies interested in this, in the underlying physiology. There's actually a phase 2 drug study right now with a molecule developed for POTS. Well, developed, and at least it's a phase 2 study targeting POTS. Up to now, all the research we've done with drugs involves drugs that are generic and have been around for 50 or 60 years, where we're trying to repurpose it. So the hope is that if I were to give a talk like this 10 years from now, there may be progress based on this or not. So coming back to long COVID, one of the issues that came up fairly early in the pandemic was that people started noticing that there was a lot of tachycardia in patients, uh, in a prolonged way after COVID infection. And there are a couple of reports here. The group in Sweden, particularly Karolinska, was sort of leaders in sort of identifying the issues related to tachycardia, and certainly POTS got a lot of attention as part of COVID. But this raises the question, and people started throwing around dysautonomia as being a big part of it. And so the grant that we got from CIHR was actually designed to ask the question about whether there's objective evidence of autonomic disorders in long COVID. And there's actually some recent studies on this, but the data I'll present are from a couple of years ago. The study involved bringing in patients with long COVID. So some were just responded to ads, some were referred, fairly broad swath. And the work that I'm going to present was pretty much all led by Rushman Hira, who's a PhD student in my lab. Right, so we came up with a protocol where, with beat to beat monitoring of blood pressure, so continuous heart rate and blood pressure monitoring, we created a stand protocol. We didn't use tilt table testing for this. And there are different reasons for this, but what that allowed us to do is actually pick up the hemodynamics for 4 different sort of clinical autonomic disorders. So POTS, or postural orthostatic tachycardia syndrome, has been mentioned, and um, that involved an excessive increase in heart rate on standing. So we have that, the heart rate increase of greater than 30 beats per minute. Inappropriate sinus tachycardia, or IST, are patients with a high resting heart rate. Orthostatic hypotension, or classical orthostatic hypotension, involves a sustained drop in blood pressure on standing or tilt. And then there's initial orthostatic hypotension, where there's a rapid drop in pressure with recovery. And the last one is actually something you would miss if you did a tilt table test. You can only actually pick that up, or you pick it up better with active standing. So this is an audience participation portion. I'm not sure we're actually set up for polling. So I'll just get you guys to think about this and vote in your mind, if you will. Right. So of these 4 disorders, the question is, what is actually the most common disorder of orthostatic intolerance? So the options were POTS, inappropriate sinus tachycardia, orthostatic hypotension, or initial orthostatic hypotension. Right. So while you think about that, this is the demographics of our patients. The average age was 42 years. 75% were female, which I think fits what we see in other long COVID studies in the broader long COVID demographic. It's important to note these patients weren't studied early, right? Mainly because it took us a long time to get the kinks worked out and the logistics um, worked out. The patients, on average, were over a year after the COVID infection when we first studied them. So this was not, an early presentation issue. And this is what we found, right? So we looked at CAA as any cardiovascular autonomic abnormality. We found that in 73%. But the most common finding wasn't POTS. We found POTS in a significant number, a significant proportion. It was about 30%. But we actually found initial orthostatic hypotension to be present in over 60%. Now, obviously, one or both could be present. So, these numbers don't add up to 100. In contrast, in our series, orthostatic hypotension, classical orthostatic hypotension, and inappropriate sinus tachycardia were quite rare. Now, one question is, POTS, is traditionally a female-dominated disorder. So one question is long COVID, are these autonomic disorders female-dominated? And it turns out the answer is a bit more complicated. It depends. It depends on which disorder. So similar to what we've seen in POTS pre-COVID, overwhelmingly the patients that had the excessive tachycardia and met criteria for POTS were female. But if we look at the initial orthostatic hypotension, it was much more evenly distributed between males and females, right? So not as much female predominance to that, which raises a point that may be of more interest to those actually doing the research, that one, it's important probably to do sex aggregated or disaggregated analyses. But the other point is actually a broader one, and that is that I think it's difficult to treat long COVID as a single thing, right? I mean, I think, our management approach actually, at least in terms of these autonomic disorders, really depends on what the presentation is and what the individual patients have. And so I think, at least when they come to our clinic, this type of information, this type of testing can be helpful. Okay, so I'm going to shift gears and discuss POTS, because our approach to long COVID POTS is very similar to pre-COVID POTS, or what we thought we knew. Right, so the criteria for POTS are listed here. It involves physiology at one level. So you have to have an excessive increase in heart rate on standing. In adults, that's an increase of greater than 30 beats per minute. The one challenge is that, and this has to occur in the absence of orthostatic hypotension. The challenge with orthostatic tachycardia is that it's physiologic and it decreases with age, right? So in young kids, their heart rates go up a lot on standing normally. And as we get older, that increase in heart rate still occurs, but it starts decreasing and it's not as robust. And so there were a lot of kids being diagnosed as having excessive orthostatic tachycardia based on the 30-beat criteria. And so the group at Mayo who came up with the original criteria did a study in kids and realized this. And so the criteria were redefined to require an increase in heart rate of at least 40 beats per minute in patients aged 12 to 19. So the 30 beats is 20 and above. Now, if you have orthostatic tachycardia in the absence of orthostatic hypotension, you have POT, right? You have postural orthostatic tachycardia. That's physiology. Legal in Canada, by the way. But you don't have POTS. The key to POTS is the S, right? It's the syndrome, right? So basically, patients have to have symptoms that are worse when they're upright and better lying down. It's an orthostatic disorder. So you need heart rate and blood pressure. Heart rate and blood pressure is not enough for a diagnosis. Now, the specific symptoms we'll get into in a future slide, and they can vary, but the point is there has to be an orthostatic component. Now, everything I've described up to now, the symptoms and the tachycardia, can occur to almost any of us if we get a bad cold or a flu, right? I live in Calgary. I'm quite excited. I think the temperature is just above freezing. It was minus 30 a couple of weeks ago, right? But what that means in the winter is that we're good for a virus at least once a year for most of us. And if you feel like your inner scientist coming on, when you feel like crap, assuming you don't already have long COVID, but if you're otherwise healthy, when you feel like crap, if you actually measure your heart rate and blood pressure, you may well have orthostatic tachycardia. I'll go through some symptoms. You may well have that, right? So a lot of this is actually a normal acute response to an acute viral illness. The issue in POTS is for most of us with a virus, it gets better in a few days. In POTS, it hasn't, right? So it's a chronic disorder, similar to long COVID, where there's a 12-week rule to sort of, fully meet that criterion. We require at least 3 months. It used to be 6 months. It sort of has been sort of whittled back to 3. But the point is, it's a chronic disorder. It's not an acute disorder. And to make a diagnosis, you have to exclude other obvious causes of orthostatic tachycardia. So big ones are drugs, very prolonged bed rest, some physiological, other diseases that can lead to either severe dehydration or tachycardia directly. So a few years ago, we were coming up with a Canadian Cardiovascular Society position statement on POTS. And what we realized was that there was a problem. And the problem was that we all recognized that POTS required both a lot of orthostatic tachycardia and a lot of orthostatic symptoms. So, we came up with a nice Cartesian plane. But there were patients that had symptoms, orthostatic symptoms, without enough tachycardia. And, one of two things would happen. Either they'd go into the doctor and, they would be told you don't have POTS. And sometimes what the patient would hear, even though that was technically correct, what the patient would hear is there's nothing wrong with you. Um, or sometimes patients were diagnosed with POTS incorrectly. And the problem that we realized we had was an inadequate nomenclature. There wasn't actually something to account for these variants where it wasn't POTS, but it was something, but it wasn't POTS. And so we came up with a few other terms to try and account for this. The big one was, postural symptoms without tachycardia, where you have a lot of symptoms but not the excessive tachycardia. This, people have protested because the acronym, as an acronym, it's horrible, right? PISWIT doesn't really sound, doesn't roll off the tongue like POTS. So if you guys can come up with a better acronym, that might be helpful. But what it does do is actually acknowledge that there are people, a lot of people in this situation where they have these orthostatic symptoms, and we need to acknowledge that and start figuring out what that is. The other thing that we realized was that in the POTS literature, there are two problems, right? Some people thought of POTS, or two groups. Some people thought of POTS as purely a cardiovascular presentation. It's all about the heart rate and the blood pressure. You fix the heart rate and the blood pressure, you're done. While others, I think, recognize that a lot of POTS patients, arguably the majority of POTS patients, can have a significant comorbidity that often was driving their quality of life, in addition to, or even more so than the tachycardia. And so we came up with this nomenclature of sort of a pure POTS or pure postural symptoms without tachycardia, and then a plus component where there's other things going on to try and help us. If we're trying to track a drug study, for example, and want to know if a treatment improves quality of life, if you're targeting hemodynamics and the main problem is severe pain or severe headache, you're going to miss the boat. And this is trying to sort of capture that. So some of the common symptoms I've alluded to in POTS are listed here. I'm a cardiologist by training, so I've broken it down into things that I can blame on the heart on the left and things that I have a lot of trouble blaming directly on the heart on the right. So in a tachycardia disorder, you'd expect the palpitation, the sense of a rapid heartbeat, chest discomfort, shortness of breath, lightheadedness. But almost as common, patients will complain of mental clouding or brain fog, headaches, nausea, tremulousness, or shakiness. Things that, again, harder to blame on the heart. Everything in black that I've talked about tends to get worse when they're upright, when people are upright, and better when you're not. Not necessarily totally better, but better. But there are symptoms that are not positional as well. So almost everyone has significant exercise intolerance. Basically, everyone is severely fatigued, and sleep complaints are incredibly common. And we don't ask patients to sleep upright. So there are non-positional issues as well. This is a tilt table test done several years ago of a patient with POTS on the right and a healthy control subject. This was a Vanderbilt grad student on the left. And what we see are three channels: a heart rate channel on top, a continuous blood pressure in the middle, and the bottom is the tilt angle. You can see where we tilted the patient up and then tilted the patients or the volunteers back down. The first thing I want you to notice is that the POTS is not a orthostatic hypotension disorder, right? If you look at the blood pressures, you could look at it and say they look different, right? The POTS tracing looks like I do when I wake up in the morning in need of a haircut, right? Spiky and all over the place. And it turns out that actually is probably important. Those spikes are telling us something. But you can't look at it and tell me the blood pressure is lower in POTS. It's not an orthostatic hypotension disorder. The second thing is if you look at the heart rate in the control subject in the top right, or top left, sorry, the heart rate goes up. Orthostatic tachycardia is present. Orthostatic tachycardia is physiologic. But the POTS patient on the top right does it better, right? The heart rate goes up a lot more. And in this particular participant, she didn't make it through the protocol, which was a 30-minute tilt. She actually made a stop early. And when she did, her heart rate was almost 180 beats a minute, right? And all we had done was tilt her up, right? So excessive orthostatic tachycardia, lack of hypotension. But as I said, The key is the symptoms. And in this protocol, we were actually tracking symptoms every 3 minutes. The control subjects in black, you can see, were basically asymptomatic. Every once in a while, someone would get a little bit symptomatic and then would faint and drop, the data would drop out, right? So the group is largely asymptomatic. The POTS patients, on the other hand, were symptomatic early and they kept getting more symptomatic until the end of the protocol. Like they'd tell us they were going to faint and they kept telling us. Now, the interesting thing about these data are that a higher proportion of the POTS patients made it through the 30-minute tilt protocol or survived it than the healthy controls, right? More of the healthy participants fainted actually during tilt than the POTS patients. So the point here is that POTS isn't primarily a fainting disorder. POTS is a feeling faint disorder. Patients felt like they were going to faint, but a smaller proportion actually fainted. Some do, but a smaller proportion than the healthies. I'm going to shift gears and talk a little bit about what to do. The evaluation itself is fairly basic, the initial evaluation. It involves a detailed history, right? I mean, it takes time to um, sort out the what's going on because, as I imagine people on this call have experienced, right? There's lots of odd um, symptoms and things going on. It's sometimes difficult to figure out what's related and what's not, right? So this is actually part of the challenge in terms of medical care is that, you can't do this in a 10 or 15-minute visit. So it's a lot of history, a little bit of physical exam. Obviously, you can't diagnose an orthostatic disorder without orthostatic vital signs, right? So in POTS, you have 10 minutes to reach that 30 beat increase. And so you need lying and standing heart rates and blood pressures over at least 10 minutes. There's a bit of basic blood work that's recommended in the Canadian Cardiovascular Society's position statement, a hemogram to make sure you're not severely anemic, a basic electrolyte panel, a thyroid, TSH to make sure your patient's not very hyperthyroid. I would argue a random cortisol is probably reasonable to make sure someone doesn't have Addison's disease, that you don't have full-blown adrenal failure. To be clear, we're not talking about subtle adrenal glands not working perfectly. What you don't want to miss is full-blown failure. There are a whole bunch of other tests that can be done. Some are listed here, but the list can go on and on. But the rest should actually be directed by your initial evaluation. Um, I'll make one point about an echocardiogram. Patients with POTS, at least grossly should have normally functioning hearts. Right? We're doing a study to pick up if there are more subtle abnormalities. If your doctor can examine you properly and determine that the cardiac exam is normal, that's great. If not, it might be worth getting an echocardiogram or an ultrasound of the heart because I was referred a patient who apparently developed POTS in pregnancy, and that can happen. And I was seeing her shortly after she delivered. And it turns out what she developed wasn't POTS. What she developed was something called a peripartum cardiomyopathy, where the heart actually wasn't pumping properly, and the treatments are quite different. In fact, in a lot of ways, the opposite. So you don't want to miss that. I'm going to talk about the foundation, I guess, of our non-pharmacological approaches, right? So I want to be clear, this isn't an either or with drugs. This is actually something that I think we recommend for all the patients. And then depending on the other symptoms, we will, add drugs as needed, right? But the non-pharmacological pillars consist of dietary salt, and I probably should add water here, compression garments, and exercise. And we'll talk a little bit about each. So for years, people have recommended high salt diets to patients with orthostatic disorders, but until recently, there was actually no data that had actually worked. So this was the last study I'd conducted, last grant I had at Vanderbilt, um, included this dietary salt study. And basically, it was a crossover study where we brought in patients with POTS and healthy volunteers, all female, into the research unit at Vanderbilt for 2 one-week stays. This was an inpatient research unit. And for 6 of those 7 days, we did nothing but feed them. We fed them either a very high sodium diet or a very low sodium diet. And then on the 7th day, we didn't rest. On the 7th day, we put them to work and we actually did various tests. And we looked formally at the blood volume. We did posture studies where we looked at the heart rates and blood pressures and collected blood lying and standing. And what we found was, get into details later if you want, but what we found is that high salt diets did what we thought they did. So acutely, so 1 week of a high sodium diet compared to a low sodium diet increased the blood volume. Specifically, it increased the liquid part of blood, the plasma. It didn't actually alter the red cell volume. It's unclear if we did this, if we assessed them for a few months instead of a week, it might have actually affected the red cell volume too, but it didn't in this study. It decreased the amount that the sympathetic nervous system um, activity increased, right? And we used norepinephrine levels in the blood as a surrogate or a measure of that. So the slide is, I guess, technically incorrect. The norepinephrine levels didn't go down. They just didn't go up as much, right? And then because of that, the heart rates on standing didn't go up as much either, right? So it actually blunted the heart rate increase. It blunted the increase in sympathetic tone. It did what we wanted it to do. So from a practical point of view, this is what I actually advise to our patients in clinic, right? So I try and get everyone to drink at least 3 liters of water a day, right? And it's largely a made up number, right? But the goal is to get enough fluid in that the kidney can hold on to what it wants to hold on to. 3 liters is a lot. It's absolutely doable. Almost all my patients can do it, but it's a lot. And I've actually taken an approach where I encourage people to have a dedicated water bottle. If I go to my kitchen now, I have a drawer full of water bottles, right? But you have to sort of pick and choose and think about it. What I want is people to have a water bottle. I want it in their hand all the time. And when it's there, you drink passively. You don't have to think about it. And then if you have one water bottle, you know the size, right? And you don't have to, you can sort of do the math once that if it's a 750 milliliter bottle or a liter bottle, I need 4 of those or 3 of those a day. And then for salt, there are two statements that give numbers, the heart rhythm statement from 2015 and the Canadian Cardiovascular Society statement. And one says 10 to 12 grams, one says 8 to 10 grams. So I've settled on 10 grams as the target. Now, the challenge is measuring that, right? I can't personally sit there and add up all the little bits of salt that go in and figure out how much you're getting in. I did have a patient that actually would carry around a little kitchen scale in her purse to measure it, but that's probably too much to ask. But this is a horseshoes and hand grenade thing. This is something you want to be close with. You don't have to be perfect. And so a teaspoon of salt is about 5 grams. And so the target is actually about 2 teaspoons of extra salt a day. Now you can just take it in the spoon and then chomp hard and get it in that way, but that's kind of a painful way to do it. And so we've come up with what I call the Ziploc bag method, where we get patients to measure it out in the morning and put it in a little reusable container or a little snack bag. And then through the day, instead of adding salt randomly from whatever source you can get, you add it from the bag. And that way you know roughly how much you're getting in. Most people like the taste of salt, and so they can add it to their food. And that is the cheapest and most efficient way of getting it in. Some people don't. And if they don't, then we have to sort of look at other ways of, either adding it to the water or looking at electrolyte supplements. I don't tend to recommend salt tablets routinely. Regular, salt tablets actually I think are more poorly tolerated. There are better tolerated versions. Vitacium is one that's a coated tablet, gets absorbed a little further down the gut, but it can get expensive to try and get in the 10 grams of salt that way. Now, if you're doing that, it's worth noting 10 grams of salt is about 4 grams of sodium because the electrolyte supplements and the tablets are going to give it to you in sodium. The next pillar after salt and water is the use of lower body compression. And the rationale here is that when we stand up, fluid shifts from our chest where our heart is to below our chest where our heart isn't, right? So there's less blood that gets back to the heart. So it's a sort of this whole principle of inadequate cardiac venous return. So Kate Bourne, who is a med student now, but was a PhD student in my lab at the time, did a very nice proof of concept study looking at this, where we had a segmental compression suit and we brought in patients and we did 4 different tilt tests. The extremes are shown here, where we had one with no compression and one with full lower body compression from the abdomen down to the legs. And what she showed is that with compression, the heart rate still went up with tilt, obviously, but it went up less. And then with ongoing tilt, there was less residual increase, right? The heart rate would keep increasing, over time with ongoing tilt, that was blunted, right? So the compression seemed to help with heart rate. We looked at symptoms using the Vanderbilt Orthostatic Symptom Score, and interestingly, in what I'd call a dose-dependent way, compression improved the orthostatic symptoms, right? So full compression was better than no compression. That's what we showed you the heart rates for on the prior slide. Abdominal compression, which is actually sort of abdomen and upper thigh, sort of a bicycle short compression, was almost as good as full compression. And leg compression, and it should probably say calf and not leg, calf only compression, almost as useless as no compression. And there was a very tight correlation between the way we were able to affect the heart rate and the improvement in the orthostatic symptoms shown on the right. Right, but the suit that we used was made of neoprene and Velcro and was really ugly, and no one would actually wear that outside the lab. And so Kate did a follow-up study published early last year, and it was actually done during COVID, right? So it was a study where we had patients use garments that they already had, compression garments they had purchased commercially, with or without prescription, um, and sent monitors and the protocol to them, and they did the study at home. Uh, the QR code here will take you to that study. It's open access, I believe. Um, and the point is actually this did work, right? So we did studies. We had patients do orthostatic vitals before and after putting the garment on in the morning, showing the compression decreased the orthostatic tachycardia. They had to wear it for at least 4 hours, I think, during the day. In the afternoon, they did the orthostatic vitals again before and after taking it off. And the benefits persisted through the day. The third pillar is exercise, right? This was, there are a few studies that looked at this. The one that's often most quoted came out of Dallas, but 15 years ago. And they showed that a 3 to 6 month exercise program in patients with POTS improved of the people that finished the protocol, improved their fitness level, increased the blood volume, increased cardiac mass, increased the size of the left ventricle, decreased the excessive sympathetic nerve activity, um, all of which most patients don't care about, right? As a human physiology person, it was great information, but patients don't care. But it also decreased the orthostatic tachycardia. And some patients do care about this because this is actually something you can measure at home. And people completed the SF-36, a very generic health-related quality of life tool, and everyone that completed the protocol improved. Some a lot, some only a little, but everyone improved at least a little bit. So this is our approach to it in Calgary. The key, in the study, they had trainers, they had facilities. I have nothing, right? So our approach is to take the principles from that and let people sort of determine what they can do, um, you know, uh, and how they do it, right? Because it has to be something they can sustain. So the key is the training is largely focused on aerobic reconditioning, right? So it's focused on aerobic activity. They did have some resistance training for the legs, but it's mainly aerobic. Um, Frequency and duration are important, right? So for the aerobic training effect, I'm told you need to basically do this at least 4 times a week, every other day. Um, and the challenge is that life gets in the way. So I'll often ask patients to try for 5 or 6 days because even with the best of intents, you're going to miss days here or there because other people get in your way and prevent it. And fairly quickly, and this is a difference between our approach and the CHOP protocol. These are both modifications of what was done in the study. We try to get people to get to 30-minute sessions sort of sooner rather than later. Now, the most important thing they did in this study is that they said, okay, these patients feel unwell when they're standing. Why would we get them to exercise when they're standing? Right? And if you think about it, most times when we think about exercise, we think about things that were vertical, running, treadmills, those evil elliptical things, even cycling, right? So they wanted people to use a rowing machine if possible. If that wasn't possible, recumbent cycles, right? The cycles where you're sort of leaning back and small from a gravity point of view, or swimming. Now, I live in Calgary, right? They lived in Dallas. Everyone has an outdoor pool in their backyard. Here, we call outdoor pools ice rinks, right? So swimming isn't actually a practical option for a lot of my patients because we don't have enough access to indoor pools. But if you do, it's certainly a viable option. Um, Now, when we started doing this, one of the things we found is people would come back to us and say it didn't work. I did it for a few weeks and it must apply. This is probably good for someone else, but not me. And I had to go back and talk to Dr. Fu, who led the study. And she said, we said people got better. We didn't say it happened right away. And in fact, when we went back, it can take up to 6 weeks before patients start to see any benefits from the exercise. Not totally better, like any improvement. And early on, they may well get worse because of the issues around post-exertional malaise. But if you can get through this period, patients have told us, it's not just what we read now, we've been doing this for a while, that it's almost like a light switch flips, and they actually then feel worse when they miss days of exercise. But initially, it's a slog. So I'll just finish with a few words on some pharmacological options. Most in blue are potentially helpful. I will say the one in red here is a do not do, and I'll get to why in just a moment. So this isn't a suggestion, it's a warning. So saline helps reduce orthostatic tachycardia, and we've known this for a while. This is data from almost 20 years ago um, from a paper by Jiris Jacob, where if you look at the far right, the heart rate decreased from over 30 beats per minute to about less than half of that after a liter of saline on tilt test, right? So acutely, it works very well. Why? Well, we think that a lot of patients actually have hypovolemia, that have a low blood volume. That's part of the rationale for the salt and water part of the treatment. And saline acutely, fixes that for a short period of time. Now, should we do that more then? So saline, if someone is doing very poorly, let's say they end up in the emergency room, they're, been having a flare and doing very poorly, I often recommend a couple of liters of saline before the emergency doctor has to decide whether they need to be admitted or not. And usually it actually will get people better enough that you can avoid a hospital admission. And so acute intermittent saline is was a class 2A recommendation. This is from the Heart Rhythm statement from 2015. It's a reasonable thing to do. The challenge is actually getting saline regularly. So if you get saline weekly or several times a week or every day, that's not recommended. Class 3 is do not routinely do. There may be special circumstances where you would, but it's generally a contraindicated thing. And the issue is not the saline. The issue is not the salt water. The issue is how you get the saline in, right? So if you are doing this regularly, often you will not be able to get a peripheral intravenous catheter in after a short period of time. After a few months, it gets almost impossible. And then you have to then go to a PICC line, and then that lasts a few months, and then you end up getting a port and a central line. And the concern is over the complications of long-term central line access. The biggest, most common one are severe infections, but there are others. Mechanical, you can get pulmonary embolism, you can block off, you can get something called an SVC obstruction. There are things that are of concern, and that's the issue. We did a series of drug trials when I was at Vanderbilt. These were acute 4-hour drug trials that taught us about drugs that can be used. And one was DDAVP or desmopressin, right? So one approach is to increase your salt and get the kidneys to hold on to that. And there are drugs like Florinef that promote sodium retention. But DDAVP does the opposite. It actually tells the kidney to hold on to free water. And we use it in little boys that wet their bed at night, right? So it's presumably a pretty safe drug. Of course, we don't tell little boys that wet their bed at night to drink 3 liters of water, right? And one of the concerns is that it can actually dilute out your sodium, and you can actually cause a life-threatening complication of hyponatremia, right? But what we found is that DDAVP with half a liter of water, 16 ounces, actually lowered the heart rate. And so this can be used. And I typically have used it as a special event drug. Thursday night, you want to, or New Year's Eve, you want to go out and party and you're not sure how you're going to feel, you know, hours or days away. If you take this drug in the water, it'll plump up the blood vessels and people will feel better for a short period of time. I have colleagues, and I've done this in a handful of occasions, but I have colleagues that use it nightly, like a 0.2 milligram dose every night. And it just helps hold on to fluid in some patients very effectively. If you're going to go on DDAVP, it's important that your blood sodium level be monitored by your doctor, right? Generally speaking, at the low doses we use, 0.2 milligrams, it tends to be fairly well tolerated and fairly safe. But there's a risk that the sodium can go really low. And like I said, it can be life-threatening. So it's important to be followed so that we can back off if it's a problem. Midodrine is a drug that's a blood pressure drug unlike any other because it squishes vessels and raises blood pressure a little bit, squishes arteries and veins. This is the same study by Jiris Jacob from 20 years ago, actually almost 30 years ago, sorry, that showed that midodrine did lower the heart rate on tilt, not as much as saline. Beta blockers, you have a lot of heart rate, beta blockers block the adrenaline effects on the heart and can lower the heart rate. It's sort of, we can lower heart rate. The issue is a lot of patients don't tolerate beta blockers. They tell us they don't. Julian Stewart did a study and found that, the patients didn't feel better with IV esmolol. But when we studied it in the same sort of model, we found that propranolol that we use, low-dose propranolol, seemed to lower the heart rate and lower the orthostatic tachycardia better than almost any other drug we used, and it improved symptoms, right? It was typically the winner. But the question is why? Why did this work for us when patients would come in saying, I don't tolerate this? And it was actually Bonnie Black, our research nurse, that said we, typically use low doses and maybe it's a dose effect. So when we compared it to full low dose propranolol to full dose propranolol, we found that as we got to full dose beta blockade, patients started to do worse, right? So the key to using beta blockers is to use a little bit to take the edge off the heart rate. You don't want to fix the heart rate with it. More recently, there's a drug called ivabradine, which blocks something called the funny channel. It also works to modulate the heart rate, in the sinus node, the heart's pacemaker. There's a nice study, a small study, but a nice study from Pam Taub's group at UCSD published a few years ago showing that it lowered the heart rate and improved quality of life and symptoms as well, right? This is a bit more expensive, fairly well tolerated, a bit more expensive, and so access is sometimes a challenge with ivabradine. We've just finished a crossover study comparing propranolol to ivabradine. Hopefully, we'll be able to get that published in 2026. We wanted to look at other approaches. So we looked at acetylcholinesterase inhibitors, specifically a drug called pyridostigmine. It's on the market for a disorder called myasthenia gravis. It actually helps to prevent the breakdown of acetylcholine, which is a neurotransmitter used in lots of parts of the body, including the autonomic nervous system. And we found that acutely, it also helped improve symptoms and lower the heart rate. It is a weaker drug than beta blockers, but certainly can be used as an adjunct. This was used in a large group of patients by Blair Grubb in his autonomic clinic in Toledo, and he published a report basically saying that about 60% thought they felt better with it, but 20% had to stop the drug, and almost all of it was because of diarrhea and abdominal cramping. So if patients are prone to diarrhea, I tend to avoid it. If patients are prone to constipation, they love it. And finally, the drugs to avoid. So norepinephrine transport inhibitors are included in all of the SNRI drugs, right? So there are a lot of antidepressants and neuropsych drugs. Atomoxetine, which we use, is on the market for attention deficit hyperactivity disorder. And these drugs, when you block that transport, it's a clearance transporter in the sympathetic neurons. And so what it effectively does is increase sympathetic nerve activity. Every time the nerve fires and releases norepinephrine into the synapse, into the little gap where it can hit receptors, it hangs out for a longer period of time. And we found that unlike every other drug we tested, it increased the heart rate standing and sitting, and it increased the orthostatic tachycardia, and overall it made symptoms worse. Right? So not in everyone, 2/3 got worse, 1/3 didn't. But that's worse than any other drug we tested. And so this is a class to be wary about. And I'll just finish with a word that there's a small study published a couple of years ago by Stavrakis' group in Oklahoma that showed that a few 2 months, I believe, of transauricular vagal nerve stimulation, so ear stimulation, actually lowered the orthostatic tachycardia in a group of patients. This is something that I think several groups, including ours, want to sort of follow up in a larger study to see if we can improve symptoms and actually understand the mechanisms, but it may be a new emerging treatment for POTS. So with that, I will leave you with these take-home messages, and I will leave you with treatment guides if you want. So this is on our website. The QR code uh, will take you there. It's a downloadable PDF of our non-pharmacological approaches if it's of interest. And with that, I'm happy to answer questions, but I prefer you ask them to Danielle.
Yeah, thank you. Thank you, Satish. I saw that we have a lot of questions, so I don't want to like take too much time. I just want to briefly mention, and I was kind of like, I wasn't sure if I was going to present or I'm not going to present, so we have time for the questions. I just want to mention two things. My interest, like, so so I have two slides, really brief, but just like my interest as a neuroscientist in POTS, and I wanted to give Satish the time because he's the POTS specialist, and I think it's more helpful. But my interest as a neuroscientist was like when I was writing this text, I was like, I saw that POTS is one of the biggest symptoms and like things that patients with long COVID have. So it was just like my interest was like, well, how POTS correlates with the brain and like brain dysfunction, because a lot of patients with POTS also have brain fog and like or any like brain related changes, alterations, memory. And like brain fog is a very weird term, right? Because it's like it means a lot and it doesn't mean anything. It's like an umbrella term. So it can be like cognitive impairment, can be like confusion, can be even like anxiety, psychiatry symptoms. So my interest was like just seeing that a lot of patients with POTS also have cognitive issues or neurological issues. It's like highly connected. And one of the things that I'm really excited about, and I'm wanted to do more research is like this idea, this is a paper that actually came out a few months ago. So it's very recent. We still don't know what's the connection between POTS and cognitive dysfunction in ME or in long COVID. But what I think is interesting about this study is that they found and they're seeing that the patients with POTS, independent if it's long COVID or ME, they do have a impairment in the cerebral flow, the blood flow in the brain, so that we call the CBF. And they see in the specific brain regions, so in the prefrontal cortex, in the region that is highly connected to cognition, and also in the temporal lobe. So these are regions that we know in the brain that are associated with cognition. And the patients with POD, they have like a really like extreme, like more than half, 61% of the blood flow is reduced in this area. So they're like coming up with studies that are actually pointing that there are ways we can measure this and maybe treat. So like I think a good biomarker for this type of investigation will be brain SPECT. I think is interesting. But I just wanted to mention because a lot of people that write to me or I see online, they say, "Oh, I have POTS and I have brain fog, or I have brain fog." It is related, and maybe it is related, and is related to this high hypofusion in the brain and like this low brain circulation of the blood especially in the frontal lobe. So that's what I wanted to just mention that I think is interesting. But I think we should open for questions because I think there's a lot of questions about it, and I think we can divide. Like Satish can take care of if there are more neurological questions I can answer, but Satish can answer there's a bunch of questions for you, Satish. I think will be interesting for us to respond. I think. I don't know if we should
Yeah.
start. If Sharon, you can help us with the questions. I got a bit lost here.
Sure,
I can
Katie.
help you. I
Katie
can
can
help
help.
you with questions. Sure.
Okay, perfect.
Yeah, so let's see. There was a question about salt, if it mattered. So this is for Satish. You were talking about salt earlier in your presentation. They're wondering about the type of salt. Can you use salt? Does it matter?
So I guess, I mean, not sure how biochemically focused this is. I mean, so sodium chloride is, when I say salt, I mean sodium chloride, not other salts. But if the question is, does it matter if, like, I've been asked before whether Himalayan sea salt, the pink salt is better than, the regular table salt you get. And I, the answer is yes and no. I mean, I think from a strict blood volume expansion point of view, which is why I want to get it in, the answer is no, right? The sodium is the actually the only electrolyte I really care about. Um, Everything else is along for the ride. But the flip side is that if you're adding a few granules of salt to your food, the taste of the salt, aside from the sodium chloride taste, the taste of the impurities doesn't matter. But when you're taking 2 teaspoons of it, the taste, that's a lot. It's gonna the impurity, the taste, the side taste, if you will, probably will affect things a bit more. And so if you really like, the blue Dead Sea salt, or you really like the Himalayan sea salt, pay extra for it, right? Because, it's going to be cheaper than almost any drug that you're going to be prescribed. And the important thing here is this isn't something I need people to do for a day or two. This is actually sort of a long-term approach. So you need something that you can sustain, right? So you can't hate it every day. So if something makes it less hateful or more tolerable, then I would do that.
Okay, thank you, Satish. And that was a question from Raphael. So thank you, Raphael, for that question. Tomorrow asked, why do most patients have hypovolemia? Is it related to autoimmune disorders in general or unknown etiology?
Yeah, so I think the simple answer is it's unknown. The more complex answer is, a lot of the work we did at Vanderbilt, where we sort of started finding this around 2005 onward, right? There may be issues, subtle issues with the renin-angiotensin-aldosterone system, which is a sort of a hormonal pathway that's linked to the sympathetic nervous system. It's activated by it. It has some blood pressure role, but a lot of its role is also in blood volume, in liquid regulation. So aldosterone is a hormone that tells the kidney to hold on to sodium. Um, but the story A is not fully clear, and B, the abnormality isn't so stark that we can use it clinically, right? So if you go off and get an aldosterone level measured, it's hard to say above this point you have a problem, or below this point you have a problem, and above this point you don't, because it's very linked to how much salt you take in, for example. But there may be abnormalities in sort of salt handling and retention of salt and other fluids that's contributing to this, at least in a bunch of patients. Not everyone, but when we looked at it, it was about 70% or so. This is from several years ago at Vanderbilt when we were looking, seemed to have some deficits in blood volume.
Okay, thank you. Yeah, so there was a question about PEM, which I'm
Yeah.
personally not familiar with, but so Veronica says the mention of getting over the PEM is pretty worrying. Many ME patients have been completely disabled by following that type of advice. They might overcome it at first, but the long-term impact is very high risk. And then there was question about that and exercise. Forgive me for not
Yeah.
contextualizing this the best,
No, I
but
can
if you
I can I can
if
help with
that makes
this. Right. So
sense.
P so
Okay.
PEM is post-exertional malaise. Right. So this is sort of a key hallmark feature in MECFS, right? It's a whole principle that when you do something, you go out and you exercise, you crash hard, right?
Yeah.
Where you can't, people may describe not being able to have trouble getting out of bed for a couple of days after exercising. There are longer variants, but typically, a few days. Um, and, in the MECFS world, there's a lot of concern about exercise. And again, I can't claim to know that, certainly I've heard anecdote about this, and I have struggled to find the data about, regular harm. What I can say is that the patients I see all have um, excessive tachycardia, right? So it may be a different subgroup, but in the patients with tachycardia, the physiology does seem to improve overall, right? So this is, there's, the data from the initial study, but after that, the study came out 15 years ago. We've been recommending this, and in the POTS portion of the population, um, most patients, not everyone, but most patients do actually improve with it, and it becomes an important mainstay of treatment. It's not a cure. It doesn't make it, you can't exercise your way out of it. And I don't think it fully, my guess is it doesn't actually fully get rid of the issues around PEM, but it changes the threshold of PEM, where it changes it from day-to-day things around the house that, don't allow you to function to higher levels, where if you push yourself beyond that, you will still get PEM. But the exercise seems to increase that threshold a bit in the tachycardia subgroup.
Okay. Yeah, thank you so much. Um, so just to give you guys a heads up, Frank, it will be coming on in 5 minutes to talk about some community action and relations team activities here at the WHN. Um, and then we will be moving to Joe and Vincent, who will be heading up our data team overview. And then at the next hour, we will be hearing from Jorg, who will be putting a spotlight on Europe public health. So just wanted to give you guys all that update, and the kids' room is still going on, and we also have that option for trivia and games. All right, let's get back. Danielle, did you have any questions that stood out to you? Because there are so many questions, and I do want to
Yeah.
hear from you.
Yeah, no, exactly. I was trying to answer Henry, and I'm sorry if I'm saying your name wrong, but I think he was asking about the let me see the question again. I replied in the comments, but I missed it. Do you see Henry question somewhere?
Henry,
Yeah, trying to
um,
find because it was a good one.
Do you want me
I don't
to?
want,
I'll copy it and put it in the
yeah,
in
I'm
the.
trying. Okay.
the what, Henrik?
Yes.
Can I repeat my question about the role of autoimmunity in POTS in
Yeah, I'm trying to find this question. It was like there's so
It's
many.
it's
I'm
long. Let
trying to,
me. I'm gonna copy it
yeah.
and put it in there so it's right at the end. There you
Okay,
go.
perfect. Yeah. Okay, perfect. Thank you. Yeah.
Okay.
So it's yeah, I think everybody can read. Like it's a very interesting question because it mentions about the GPCR antibodies and how this can correlate with tachycardia. And it's one of the things we are seeing not only in patients but also in animal models. I see in monkeys as well. Some viral infections. So long COVID is one of the ones, of course, we're seeing, but we also see with influenza, they do generate some, I think everybody knows by now, that generate some autoantibodies that we can detect in the blood. And some of these, we don't know exactly why, but some patients, some people, some individuals, they generate these autoantibodies that actually mistakenly bind to beta adrenergic receptor or other receptors that control the control the blood circulation and also control like adrenaline response, noradrenaline response. So it's like a mistaken connection, like this accidental created antibodies are binding to receptors that we already know and we have in the body. And this is kind of like we can reduce a tachycardia effect in a lot of patients. And the other thing is about the brainstem. I mean, the question about the brainstem damage, it's like something that is highly connected because we know the brainstem is a part of the brain that is the major responsible for the autonomic system in the body, right? The brainstem is going to regulate the autonomic system. So if you have any like brainstem damage, you're going to have probably as a consequence a lot of POT symptoms and POT related symptoms. I don't know if Satish, if you have if you deal with this like patients with brainstem damage or any type of if you have seen this in patients directly or not.
Um, I mean, the brainstem, it's a bit harder to test because the imaging is not as good down there because the
Yeah,
bones make it a bit harder.
exactly.
Certainly, there are sort of isolated, issues where people can have strokes involving the medulla and things like that that can make things go haywire. I just want to say something about the G protein coupled receptor autoantibody stuff because we've
Sure.
actually had an interest in that and published some work, with David Kem's group when he was in Oklahoma, and then with Arthur Fedorowski. There's smoke. There's definitely smoke there, right? So using functional assays. There have been studies showing increased activity, and it's the problem is it's complicated because an early study we did with David Kem's group showed that there was a partial agonist activation of the alpha 1 receptor. So it actually activated the receptor if you added pot serum to it, but then it then blocked norepinephrine from further activating the receptor, right? So it had a pro-con effect. Um, but these assays, these functional assays, are very difficult to do and aren't not available commercially, but even in a research setting are difficult to do.
Yeah.
So a lot of people go to commercial labs that don't do functional assays, but look for presence assays. So ELISA assays that look for either parts or bigger parts or smaller parts of the antibody. They're just looking for presence, not whether it does something. And Celltrend, for example, in Germany is a lab that we have North American patients that have gone to. Um, and their assay in our hands, it doesn't work. So Arthur Fedorowski's group and I and our group in Calgary, his group in Stockholm, our group in Calgary actually pooled samples from healthy volunteers as well as patients. And then we had Celltrend do the assay in a blinded fashion. And and we published this paper in Circulation a few years ago, but we found that I think 96% of POTS patients were positive by the Celltrend assay for an antibody to the alpha-1 receptor, another adrenergic receptor, which sounds great. The problem is 100% of our healthy controls were positive, right? So again, I'm not sure what to do with that information, right? That's not to say that I think the autoantibody stuff isn't real. I suspect it is. And certainly, I think in the long COVID subset, I mean, there's clearly something related to the virus, either directly or through the body's response through autoimmunity,
Mhm.
seems most likely to be involved. But I think it's a bit more complicated and it's hard to sort of get our arms around right now.
Oh, thank you, Satish. We really could have another event where we bring you guys back, and there's so many questions. And I just want to end with Camilla's question, um, wondering, as a patient, wondering, is it safe to ingest 8 to 10 grams of sodium daily, long term?
Yeah.
Worrying about hypertension and heart-related effects is the question. And then we'll have to end there and we'll move to Frank. And then I just want to say, anybody, you had great questions, and I wish I could have gotten to all of them. So again, we have the follow-up form. So if you have a follow-up specifically for Satish or Danielle, we can do our best to get those questions routed to them. The follow-up form, Sharon. Oh, great. Thank you for dropping that in. And please take your questions right out of the chat. Just cut and paste, make it easy, and just send them on off to us. All right, Satish, the question about is that much salt per day safe?
Yeah. So I will go back to Niels Bohr, famous scientist, who had a quote that was then given credit to Yogi Berra, famous catcher for the New York Yankees, and that is predictions are difficult, especially about the future. So our patients tend to be on the low blood pressure side, most of our patients. And so in the short term, measured out to several years, it seems to be safe. But the truth is, I don't have long-term data to share with you to say it is. And I think what I will tell patients is that physiology in general changes in middle age, right? That's when primary hypertension tends to develop. And so I think it's the advice for now. Often our patients are in their 20s, and it's the advice for now. But when you're in your 40s or 50s, if your pressure is high and not low, then the advice may change.
Mhm. Okay. Um, Thank you so much for that, and thank you both Danielle and Satish. We will follow up with you for coming back because clearly, like this is such a important topic for many. All right, and for all of us here. Thank you. All
Thanks for having
right,
us.
you're welcome.
Thanks
All
so
right, let's.
much. Great presentations.
Thank you. We'll have Frank come up on the screen. Thank you. Okay. All
Awesome.
right, Frank.
Thanks so much, Katie. And thank you, Satish and Danielle.
There you go. Thank you so much.
Okay, to get started. Okay, thank you. Hey, everybody. So I'm Frank. I work on a few teams here at WHN, and I'll be sharing a little bit of info about things that are in the works from those teams. And I'll also be sharing some links in the chat once I wrap up. So I'll be quick, and then we'll pass it back to Katie. The first team I want to talk about is the Community Action Team. That team meets on Fridays at 3 p.m. Eastern Time. And the Community Action Team is working on a project with the website team to establish a web page that'll serve basically as a hub for people to learn about COVID conscious resources available to them, like their local mask blocks and events local in their community, virtual events, both WHN events as well as non-affiliated ones. And I just wanted to also mention that the Community Action Team meets weekly to discuss community action happening locally to our team members, projects happening inside and outside of WHN, as well as having organic discussions that have been really great in helping us create messaging. That's number one. Number two is just some information about the relations team. We've got two projects that are happening early in 2026 that might interest people. And the relations team meets on Mondays at 3:30 p.m. Eastern Time and develops relationships with organizations and people outside of WHN. And we're working with WHN's events team to develop a calendar of presentations for the Daily Call speaker series. For those of you that don't know, these are 10-minute, 10-ish minute informal talks that give people a platform to share on topics related to science, community engagement, or other public health related topics. So be on the lookout for that. We'll have a weekly speaker. If not weekly, that is the goal. We're going to maybe do something bi-weekly or a couple times a month, something like that. And then the relations team will also be working on another program. Last year we launched our liaison program, and we're going to be seeking to expand on that. So liaisons are designated members of the relations team who are trained and trusted to work on projects that require coordinated outreach with other organizations or people outside of WHM. Again, I'll be sharing relevant links to these things in the chat if people want to check it out. And I'm seeing Sharon put some things in there as well, so thank you. But lastly, I also wanted to note, because we have gotten this question, and we've got, we know that there are some people who are new to WHN at the New Year's party here, so thank you for joining us. But we've gotten some questions about credentials and things that might be required to join WHN. We just wanted to let everybody know that all are welcome to join, and participation is whatever you'd like to make of it. And we're excited to see new people join your community. So welcome. And I'll go ahead and drop those links, whatever Sharon hasn't shared. Thanks, Katie, and thanks, everyone.
All right. Thank you so much, Frank. I would like to announce our next speaker. Gregory Kirchhoff is going to be doing a presentation on data visualization. And I also would like to, anyone who's new and curious to the WHN, you could always meet with Sharon. Sharon's offered to do a welcome session with us. And if you would like to do a welcome session now, essentially, as an alternative activity, and you had questions about the WHN, feel free to just drop into the chat and we will create a breakout room for that. As a reminder, we also have alternative games and trivia in the other room with Sharon. So lots of options here. And let's kick it off with Gregory. Do we see Gregory co-hosts? I don't see his name popping up. So we might have to make him co-host.
I will spotlight him. So he's
There we
spotlighted
go.
now. So if you want to make him co-host,
Thank
in
you,
case he wants to
Gregory.
share.
Oh, thank you. Yes.
Thank
You're all
you.
set with your tech fixes.
Awesome.
Thank you.
Let me share my screen.
Okay.
And good morning from Japan, by the way. Good morning from the new year.
Thank
Don't want to give
you.
any spoilers, but it's pretty good so far.
Nice, nice.
So far, so good.
So far, so good. And so this morning, what I'd like to talk about is our struggle as a society and as individuals with saying, I don't know. The consequences of avoiding that phrase, and how to better communicate and navigate under uncertainty. And it's an understandable and well-described problem. We suffer from ambiguity aversion and cognitive closure, where we feel discomfort with unresolved questions. And we're primed to see those as not providing clear answers as inept. And so this has unfortunately resulted in widespread outwards overconfidence. We demand it from our politicians, peers, and selves. And the downstream effects of this have been highlighted by our current pandemic all too well. There was a lot of surety given about how it spreads, who is unaffected. Where you can see that children in the beginning were often seen as being completely spared, but now we know that long COVID in children in pediatric populations might be one of the top, if not the most common chronic health illness for children in America. And also that this will all just go away by itself due to, for example, reinfections being negligible, evolution acting directly, almost narratively towards some kind of symbiosis or friendship. And about long COVID itself, that was confidently bollocks. But we know that this all, of course, turned out to be incorrect. And so it appears that we live in a probabilistic world with rewards and consequences. And we unfortunately can't get a crystal ball to get all the answers. And so we're going to have to figure out a better strategy for communicating and navigating under uncertain territories. And by the way, these screenshots here come from when I was a TA in college. And this is a strategy that a couple students came up with. True false is it's a pretty good bet. It's a 50-50 probability. And so the fear of probability or chance caused these students to irrationally turn a good gamble into a guaranteed failure. And so we want to start off with a bit of a rebrand, where we want to reframe cluelessness as uncertainty, which is actionable and often measurable. And so for communicating uncertainty can be visualized. And the conventional way is usually through showing confidence intervals or viewing probabilities as frequencies. But rather than relying on busy people thinking about statistics, I found one of the best ways to communicate uncertainty is to account for the range of possible outcomes in a more playground-like experience. So using the, per infection risk of long COVID, for example, it's very difficult to measure now and is apt to change as we adjust and rethink about diagnostic thresholds, how we measure this. And so it's very difficult to come out and say, here's the exact risk of developing long COVID per infection on average and how it evolves over time based on reinfections. That's just not possible. But what we can do is to familiarize ourselves with the range of plausible outcomes and refine from there. And another positive about this approach is that although people aren't naturally inclined towards statistics, we are naturally drawn towards play and tinkering. And another kind of effect is that a side effect of the rampant overconfidence in society is that people have grown a distrust of officials, but creating playground-like visualizations like this allows for people to form their own relationship with the concept and how to think about it. And actually, just recently, an article was published that said incidence did not decrease over time, reinforcing long COVID as a continuing concern. I had no idea at the time of making that visualization that this study would come out, but it was accounted for in the range of results of it. And the same goes for delayed health effects of COVID-19 infections. Acute and chronic exposure to various harms like cigarettes, asbestos, and chickenpox come with chances of delayed harm, but this is a tough thing to talk about because we just haven't had that time with COVID-19 yet. But we still need to talk about it. We need to take a look at the current evidence and try to build a sense of the possible outcomes that can happen. And one last example was a project that we did for the WHN summer internship event. As was said before, measuring the exact prevalence of long COVID is difficult to say, but what can be surely said is that regardless of what study you use, it is not rare and it is underappreciated through means of funding and public interests. And so by accounting for this uncertainty, we can make more robust statements and a stronger case for action. And speaking of that action, once we encounter evidence of possible harm, familiarize ourselves with the range of possible outcomes, it really just becomes about the precautionary period. And what I want to drive home is that it really does not need to be that complicated. An example of risk we handle pretty well is tucking our socks when hiking and doing tick checks. Like you can bring in all the statistics you want to assess your own risk about this. You can calculate and parameterize how long you're going to go on a hike for, the density of ticks in your geographic range, the distance you're going to hike, and make a confidence interval of should you tuck your socks in or not. Or you could just tuck in your socks because it's very quick and easy to do. And tick-borne illnesses like Lyme disease and alpha-gal syndrome are really bad. In the face of uncertainty, low-cost, low-effort interventions are easy wins. So then, what are some good easy win precautions to take against a novel pandemic virus that looks to be causing acute and long-term harm to ourselves and society as a whole? Thankfully, we have some pretty quick and easy ones that have been described well by others. Thank you.
Thank you. Thank you so much. Awesome. If you'd like to be in touch with Gregory, Would you mind putting your contact information in the chat? Thank you so much. If the co-host, uh, did we have time for questions? I think we do. All right. Let's see.
I'll
Did
send
you
some
see
links to
if there was
some of
any?
the tools that people can play with.
Okay. Thanks. Did you see any questions, Gregory, that you wanted to answer? Because we have a little bit of.
I see somebody saying statistics is awesome, so that's always good to see.
All right. Well, if there aren't any questions,
Oh, Katie, you might have accidentally muted yourself.
And there we go. Just linked some of the tools that people can go check out.
Something happened with Katie.
I think so. I saw her there, and then I think I saw two Katies, so it might be a two-device situation.
Greg, do you want to talk through a little bit more the example that you have on the WHN website?
Yeah, sure. This one was a really fun project, and we'll talk about it again with the science data team talk. But I'll just share my screen briefly. But this one was a really fun project, and I guess doing my little spiel on the of what I was going to say in the science data team one was that this was done with the WHN internship project, and what that really showed and what that involved was teaching a group of people how to do this, how to make interactive data visualizations, and they started with no experience, which shows that not only is the ability to learn, like how to interpret this, very learnable, so is even being able to create it. And they learned very quickly and did what I think is an amazing job. And so what we did really was wanting to show that, because a lot of people will say, if you just come out and say, oh, this is the chance of long COVID and talk about it from there, people will, of course, dispute that. People will say it's lower, people will say it's higher, they will define it differently than you. And so what we wanted to do is say, okay, then have it your way. There's tons of different studies that do say tons of different numbers, but what can all be said as a guarantee across these is that there is an official definition of what a rare disease is. It's 1 in 200. It's a disease that affects less than 200,000 Americans, and that's the official definition. And based on pretty much almost every study, long COVID is far above that, which means that none of them, by definition, can be seen as rare. And so we also want to show with that approach of saying, like, what is the search interest? What is the funding that long COVID is getting compared to these other illnesses? And that when you view it as a ratio of that funding or search interest, you can see that, based on the perspective or measurement taken, that long COVID is very, very underappreciated. So not just that its prevalence is high, the amount of prevalence it has compared to how much funding it receives or public interest is far too low. And so that's what we wanted to do is be able to encode that in a way that isn't just us saying top down, this is how it is, kind of allowing readers to form their own opinions and relationship with that concept and idea. And being able to, again, make a more sort of robust statement from that. And also from this too, just as a message, just because so many people here are new, is that again, this is all very readily learnable. So if you'd like to join the science data team, we now through this WHN summer internship program, we set up a pretty smooth pipeline of onboarding and training and teaching people new skills. And it's, the world needs more people who can spread good, easy to transmit information.
So we have Joe and
Go ahead.
Vincent here from our WHN data and analytics team. They've been doing phenomenal work. Vincent also helps us maintain our website, which we're so grateful for. Yeah, so just bear with us for one moment while we work out the tech kinks. Thank you.
Can you see my full screen too?
Yes, Vincent, you can
We
go
can
ahead.
see your full screen.
And we can hear you. Go ahead.
Oh, perfect. Yeah, so this is just to give you a very short overview of what we're doing at the data science team or data analytics team at WHN. So basically, we turn messy public health data into tools people can use, like dashboards or models or analysis. And yes, if you want to join a project or start one, we'll help you with it, with the scoping, with data pipelines, with implementation. Best way to reach us is through Slack. I'm going to go there in a moment, how you can get there. You can also just email me at the address that you're seeing there. It's all good. So the projects I'm interested in currently and working on are long-term consequences of repeated infections at the population level for COVID. Also more general risk calculator project, but I'm also helping in with all the other projects that we have in the data science and analytics team that you're going to hear about more today. I'll show one concrete example that is about estimates of infections based on wastewater data. And then I'll hand off to Joe for forecasting and his MAPS project. Then David, who's going to talk a little bit about CO2 monitors. Amir, who's going to share some information about the energy balance app and our agent-based model paper. And Greg again, so you're going to hear again from him about this long COVID tool or article. Maybe we can jump this because you already did a great job just now. You can decide, Greg, if you want to do it again. So just shortly for you to know how you can get to us. So this is you can if you go to the WHN website, WHN Global, under the network hub, we have several pages that are very good for newcomers. The welcome page is very good, and here you can join our Slack community. This is really where all our the main projects from us are living, and so that's one way of doing it. The project I'm going to show you is the one that we have had live for quite a while now. We started out at the beginning of the pandemic with showing all kinds of data regarding infections all over in all kinds of countries and regions. Even we were on the county level in Germany and in other countries where we had just so much to show. Obviously, over the years, some of this information has become rather scarce, unfortunately. But we do have some information, for example, through wastewater data. And then the question is, okay, so how does that translate into, for example, what's going on? Like how many people are really infected, right? We are here, the simple question is just like what infection levels are likely right now based on wastewater. We have these graphs, and you see there's a little uptick again in the United States. We don't only have it for the United States, we have it for nationwide, but also for several of the states. We also have it for Germany. But if you, for example, are out there, you say, hey, I think we also have wastewater data in our country. And I'd like to know about the number of infections for us. Then this would be one way that you could help us. We could add this data to our visualization here for your country too. So yeah, it's an automated pipeline. It pulls the wastewater data and related signals, and then we are producing these weekly estimates. And obviously, when official sources, they sometimes pause, right, for all kinds of reasons. They change cadence or whatever. So we use backup approaches and adjust the pipeline. So yeah, this happens all the time. And then if very shortly, if you're interested in how we did this particularly for this tool here, we have a range of minimal or maximum infections, and we are estimating it based on a time when we were still pretty confident in both the ability for us to detect cases, to know how many infections there actually are in the population, and in the testing capacity. So, at the beginning of the pandemic, well, we didn't have maybe much testing yet, but that was solved around like a year or so, a year and a half into the pandemic. The testing had become rather good. Then after winter 2021, when Omicron was there, we again lost track of how many people were infected. But there was like a sweet spot where we had a pretty good idea of how many people got infected. Could at least adjust very well for that, and so we were able to calculate a conversion factor, and now that we know still the wastewater concentration, we can basically apply that factor and see a little bit. Okay, so where are the infections right now, and minimum and maximum that you're seeing here depends a little bit on over time mutations have accumulated, and some papers have found that maybe our ability to detect the SARS-CoV-2 in the wastewater has also suffered based on that, and so there's some adjustments that can be made. But yeah, if you're interested in the details, like there's a whole section about the methodology, and obviously some different approach here in Germany and so on. You're gonna see. All right, so this obviously naturally connects to forecasting. So the second part of this page here is a little bit more about forecasting, and like if you combine wastewater levels with variant proportions and other signals, then the question is, so where are we headed next, right? What do the trends say, and so on. So that's what Joe Eastman's MAPS work targets, turning surveillance into forward-looking insights. And I'll pause here. Please, if you have any questions, put it in the chat as we go, and we'll do a short Q&A at the end of all of the people that you're going to hear. If you want to join a project again or start one, ping us on Slack or email me. So I'm going to introduce Joe next. Let me just stop here. Hey, Joe. Joe Eastman is a highly accomplished research scientist with over 30 years of experience in numerical modeling, climate research, renewable energy, and atmospheric sciences. He has made significant contributions to the development of advanced predictive models, including work on NASA's award-winning Land Information System. Throughout his career, Joseph has combined atmospheric, ecological, and land surface modeling to advance climate and renewable energy research, optimizing wind and solar energy production for large-scale applications. An experienced educator and mentor, he has guided students from elementary through graduate levels and authored over 40 peer-reviewed publications on topics ranging from regional climate modeling to land use impacts on weather. In retirement, he continues his commitment to scientific communication and innovation, developing tools like the multiple algorithm pandemic software MAPS, that's the one he's going to talk about right now, and sharing insights through his public science newsletter. And he's also just an amazing human being and friend. Thank you so much, Joe. Please go ahead.
All right. Thank you for the warm introduction. Hopefully you can see my screen. I'm going to really go fast through these slides, but I believe that you'll be able to access them later through Katie or Sharon. So welcome. New Year's almost here. Um, and I continue to work on the model, of course. Uh, what you can see here is a kind of a example of the wastewater data that Vincent just talked about and is so vital to our modeling efforts, not only mine, but also other forecasters. Currently on the website, we provide Dr. Herger's uh, PMC 19 forecast. Mike is a good friend and a gentleman. He uses a statistical approach to predict the SARS-CoV-2 going out roughly 9 weeks. And he's worked through these different regressions and training sessions on the IHME infection data that we use to, like Vincent said, calibrate our wastewater to get our new daily infections, NDIs, they call them. And we continually update as the wastewater comes in. If you need any technical assistance, you can go to Mike's uh, appendix that he has on his main page, and you can see the link I provided above. Every week on Mondays, he provides these predictions and analyses. For instance, the heat map of where things are really high. Unlike CDC, he uses real colors to represent things, with the dark red being the hot spots. Then he also provides a post analysis and goes through state by state and gives you statistical chances of how likely you are in a room full of X number of people to acquire an infection. You can see here that his current forecast, he has it peaking on the 27th of this month, already peaked at 961,000. And then he breaks down the infections and gives you a long COVID possibility assessment based on his model, and also excess deaths, which is really important. He creates the national tables and state tables and gives you a barometer of things to come. On the right side here, you can see his current forecast, and it appears to rapidly decline after that point. I will go over now the multiple algorithm pandemic software maps. There's all kinds of algorithms that I've developed over the last 6 years that include mitigation strategies, air travel, meteorology, masking, vaccination, hospitalization, mortality, spreader events like sporting events and things like that, or major social events. And then finally, the initialization routine. The model is able to predict SARS-CoV-2, measles, influenza, and possibly H5N1 if it goes human to human. And we can add basically any airborne pathogens to the model that we have data on. It's a pretty complicated model. You can see here in the center part, it has to be parallelized because there's so many grid points in the maps domain. It's over 7,000 by 4,000 in the east, west, north, south directions. We use the message passing interface, MPI, to break up the domain into as many regions as the user wishes. Typically, I use 4. Once I go global, we're going to need all 64 of my processors, more than likely. And then MPI breaks it into these domains, and then the MPI is used to communicate between the domains, because you might have flights leaving from Los Angeles to New York. So you got to pass this information from the airlines schedules to separate domains, separate processors. You also have to communicate across the boundaries between each domain. The model's pretty versatile. You can use it for investigative research like mitigation strategies, possible new or emerging pathogens, travel impacts, or go back and do historical analysis. Primarily right now, I'm using it to forecast 4 months out. And we, the grid is 1 kilometer, little pixels, and typically it is 4 months. And the goal is to help provide people to plan for future events like medical or dental appointments or other social gatherings. So with that said, this is kind of the meat of it. You go through a solver, you got to solve all these differential equations simultaneously where you break things into a compartment model, unlike this statistical approach that Mike uses. There you have a population that is susceptible, and then they get infected and they're pre-symptomatic, and then they go into asymptomatic and quarantine pools. And finally, the recoveries are calculated. What we do and why this work with the wastewater is so important is we combine the wastewater data that we have going back typically 6 months. I got to calculate how many people have been infected by what variant, et cetera. And then we combine it with the CDC product of variant proportions. This is the current state in the United States. And you can see XFG is currently dominating very clearly. NB.1.8.1 is almost gone. And these two are combined. And then we remember we also have the wastewater derived new daily infections on a state level. So we can initialize each grid point. Of course, they got to have a population in it. We're also working on a WHN update of GIS-derived variant proportions. And why this is so critical is not only does it include more variants, it has roughly 600 variants in there, and it's done at a national and state level proportions. And it will be done on a weekly basis, whereas the CDC proportions come out every month now. They used to be weekly, but they're not anymore. Here's some guidance work that I've done in the past. I used to help local officials at the county level, providing them with forecasts down to local regions, like where I live in the Itasca County, and the Mayo Clinic was very interested down in Olmsted County. And you can see it, we're animating through time on the bottom of the screen here. This gives you an idea of how detailed it is. Like I said, it's 1 kilometer grid cells are roughly 0.6 miles. And here's the initial fields for Texas that were created by combining the variant proportions and the new daily infections. And then if you want, you can go into further detail. Take this area here, and you can see it blowing up. And each one of these little tiny dots is one of my pixels that I forecast on. The MAPS forecast, if a state meets our data criteria, then we use it. We want that homogeneity in there. And the NDEIs are calculated for each variant at all populated grid points. One single forecast actually consists of 20 separate integrations, and I create an ensemble average. And then the maps on the grids spits out a 4-month forecast of new daily infections, possible log COVID outcomes, hospitalization rates, and mortality at each grid point. Looking ahead, and Greg was discussing this earlier. We want to provide an interactive graphical display of the maps output where you can look at national, state, or user-selected area animations of new daily infections, for instance. Also, line plots and tables at a specific location if you want to focus in on your city. Um, and then we'd like to be able to provide the output so that others can analyze it. Finally, I'm going to expand maps. I've done it on a hemisphere level, but I want to get it on a global level so that we can have a global forecast on a closed system. And what that means is I don't have to worry about these boundary conditions. Like when I do forecasts for the United States, I got to have an idea of where the planes are coming in internationally and what their current infection rates are, and provide that information as boundary conditions. We are also going to finish the development of the GIST-derived variant proportions data set. And I'd like to mention starting in January, about mid-January, every Monday I will begin a weekly 2 to 3 hour Zoom space. And the links will be provided by the WHN and also through social media. And during that time, the space will first go over Mike's forecast and also the MAPS forecast. And then we'll transition into a period where we discuss the critical literature and important policies that maybe cropped up over the past week, such as like Yanir referred to the HICPAC and things like that. Then we move into a third segment where I will feature a guest, and they'll be able to present. Give a presentation if they want, or otherwise I will just interview them and finally open it up to a question and answer period. And then we'll finish out the 2 to 3 hour time window with a social period. So with that said, I think I'm done.
Thanks so much. Thanks so much, Joe.
Yeah, let me get rid of the share.
I think
Oops.
next up would be David. David, are you around?
Hello. I'm gonna make you co-host. Okay.
Yeah, thanks. Hi from Haifa. We're getting ready for the new year in a few moments, I think. So our project for the CO2 sensor had a simple thesis. We just wanted to bring down the price of a real carbon dioxide monitor. And we set a price that would essentially make it that you don't really have to think about it. And that way people would like start seeing the wisdom of air quality controls. And apparently we're not the only ones. There are a few projects online, and IKEA just came out with their new device that is actually a true, genuine CO2 sensor. It's not an extrapolator or a proxy. It actually measures the CO2 concentration and also particulate matter. And they started to sell it in North America for $30 just now. So that was the first part of our project, and so we're quite close to the price that is the target price. And the other part is essentially how to use it, how to present it to the public, and how to have engagement from the public. And for this reason, we have a channel, design thinking channel on Slack. And I'll be glad to meet people there to discuss the human factors of how this information can be presented and what features and parameters can be added to the device to essentially make people aware and engaged of air quality issues. So that's it from our side.
Thanks a lot, David. And next would be Amir, please. Is Amir co-host?
Katie, can you make Amir co-host? I'm not seeing that he's co-host.
Hey, hello everyone.
There we go.
Thank you so much. Hi, my name is Amir and I work with Nixie and WHN. So today I'm going to talk quickly about two of the projects that we've been working for quite some time with WHN members and Nixie members. And I'm going to start with the agent-based model that we have been working for quite some time. And Leila, who is not here, Leila Hedaytfer, who is the, let's say, lead researcher in this particular research, is going to, I'm going to actually represent her. We are all working on this model, most of the members from Nixie, for quite some time. It's almost a year. And we had had a lot of changes on it, but there is a reason for it. I'm going to show you what is happening. So why do we have this paper is the main question. Most of the times we ask ourselves as well, because there are tons of other models, agent-based models out there for different epidemic models. But this particular model is designed to be very flexible, and it's also based on network. And it also helps us to quickly test policy and what if scenarios rapidly. So that is probably one of the reasons that we decided to come up with a new model and try to include pretty much everything that comes to our mind related to the spread of COVID. We started with basic turtles as agents, and then as we moved on, we decided to consider that these turtles will have some connections with each other. They are either a family, or they are in a school, or they are in a workplace, and so on. So depending on that, we started bringing the turtles closer to each other by turtles women agents over here, or people who have who are susceptible in this particular case. And our turtles made networks. So we decided to come up with a network with a connection and with a particular distribution of the nodes degrees. So these turtles create family sizes or temporal connections, which are going to be the quick period of time that network agents meet with each other. And they're going to have gender, age connections, depending on how big the size of the family is. So let's talk about the turtles. So our turtles in this case are going to have networks such as like this network. And we have a lot of parameters such as gender, age, and connections. And also we have the risk, and then the virus dynamics, and we have the incubation period, and then symptomatic duration period and asymptomatic duration period, and lots of other policies such as vaccination policies and then precaution policies. So putting them all together, and also with the control over the network, we're going to have a very flexible system that we can easily tweak the system and see the effects of the system as we move on. Yeah. I thought you're asking. All right. So let's look at, for example, network for this particular case. If we consider that we have family clusters, we're going to have hubs. And here I have actually taken out this network and I have converted it into an open order view of the network, and we see families are clustered to each other, or we can have short-term connections, which of course they apply with the peripheral connection. So depending on the type of the connections, the network is going to affect the spread of the COVID in the network, and the period of the time that the agents are susceptible and then infected or actually recovered is going to be very different. In this model, we have come up with a tree of how things are going to happen if we have a susceptible of the population. For example, we will have the infected cases. The infected cases could be totally asymptomatic, or they could be symptomatic, and then we're gonna have like incubation period for each one of them, and then, or we could have cases that we have asymptomatic for a period of time, and then they are symptomatic. So it kind of considers every kind of situation that could happen in the scenarios with the network nodes. And also we have the long COVID cases, which actually is one of the key points of this particular research. In order to have a better understanding of how the network actually in a larger scale works, we have run the model with different sizes of the network, and we have collected different types of the outputs for each one of the networks. So the result, we are still collecting the results, but it is obvious that precautions prior hand are very important, and they can prevent long COVID and actually infections much faster. And also we have noticed that the family sizes alter the dynamics of the spread of the COVID very, very heavily. So I won't continue talking too much about it, just kind of stop over here so we can come up with some conclusions. So far, it's still an ongoing research. We have written most of the paper, but we haven't still closed the conclusion section. So far, we know that the vaccination is cheaper and more effective policy, and the earlier done, the better. And timings matters rather than the intensity, and long COVID dominates long-term social costs. So I'm going to stop this research. If you have any questions, please go ahead and let me know. If not, we can move to the next. Oh, I see in the chat we have a lot. That's right. So
I think it's fine, Amir, if you can go to
Go
the
ahead.
next ones.
I
Go
can
ahead.
go to the next one. All right. Stop sharing, start the other one. So the other project, which Olga is mainly, Olga and Leila, Olga and Leila's research is mostly focused on it, and also I'm helping them with this research, is an app, which is a long COVID app. Let me make sure that I'm sharing screen. I hope I'm sharing correctly. So
Yes.
the app is energy management dashboard, and we started with a lot of ideas about how to create the app, and we narrowed down app a little bit after a few experiments, and we noticed that we should actually start with a computer version and then move to a mobile phone, and also watch compatible version, a smartwatch compatible version. So the version that we're going to talk about currently is going to be the a simple website app rather than a mobile app. So this application has multiple pieces. The most important part is going to be the track, track meal part, and the second part is the track symptoms part. So let's talk about the track meal quickly. Track meal part has the add food section, which you can actually add your, as if either you are a long COVID patient or any other user, any non-patient user, you can actually add your food intake, and it has also some recommendations for the long COVID patients as well, which they can actually refer to. So after adding the food, you'll have your food journal. So you can always refer back to your food journal and see how much of the calories and how much of the micronutrients and nutrients you have taken. The great thing about the journal is here that you can edit them, or you can review them, or you can add more records in the future. And if you have forgotten to add one particular record, you can go ahead and add down. And then we move to the analysis of the food that you have taken. So depending on what food you have taken, you'll see a comparison. The comparison data comes from the journals, which I think we have also a link to the journal papers that the data is taken from it inside the app. I mean, it's going to be accessible too. And the second part of it is the micronutrients taken. So this is still an in progress work because we are all the time updating and making sure that the micronutrients included over here match with the latest publications related to micronutrients intake. So depending on what food you take, we're gonna go ahead and include the micronutrients over here. And then this line shows the optimal line. And more than that would be just fine for many of the micronutrients, and for some micronutrients would be probably dangerous. And then the third part of the analysis would be the enhanced metabolic efficiency chart, which shows your enhanced metabolic. So in here, I don't have the data records for the past, but as you can see, for example, in here, I have taken breakfast and it has this much of enhanced nutrition percentage. So this could help a lot with the long COVID patients, and then it is based on the latest published papers on the matter of long COVID and the micronutrients and anti-inflammatory food benefits. So the last part in the section is the trends part, which you can actually see the trends of the micronutrients and the minerals that you have taken during the past, for example, 1 year or 1 month. You can aggregate it by weekly or daily or actually monthly basis. It gives you a big picture of how we have been dealing with the intake of the food. Finally, we have the symptoms tracker section, which is itself another part of the app. So depending on what symptoms you have, you can actually log the symptoms using a symptom logging card. A symptom logging card gives you the ability to add notes or decrease and increase the amount of the symptom. It's going to have the time. You can, of course, modify the time as well. And it's going to help you to refer back and see what symptoms you had when and how much severe it was. Well, at first it looks probably less useful, but if in the long term, you'll know that if you're having symptoms less severe compared to the past or not, which is a good way to kind of track the changes of the symptoms that you have. And finally, we have the personal settings section that you can apply the changes that you have over here, your weight and height, and it's going to be very important in the calculation of the amount of the nutrition you take and the amount of the calorie that you have taken. So currently it is based on metric units, but of course we can easily switch it to US customary units. I guess I can stop sharing now, and I'm here to answer questions, if any. Does the app analyze and suggest changes? It currently analyzes, but it doesn't smartly suggest changes. It provides visualizations that based on the visualizations, you can apply changes. But of course, it's a good idea to include some sort of a smart decision-making system that can give you decisions or like the suggestions. But on the other hand, giving suggestions will enter another area of the app development, which we are a little bit worried about giving suggestions in this particular case. What devices does the app run? Well, this is a good question. Currently, it's a web application, but we are planning on tweaking it into a React Native application, which accordingly will run on any mobile device. Also, we are planning on we had different types of smartwatches available on the app, but there are a lot of glitches with the smartwatches, so we are still on the decision-making process of which one of the watches we have to focus. So patients with the brain fog will have trouble making sense of all data, and well, that is a good point. We haven't thought about that one yet, Linda. One of the biggest problems, especially as an entrepreneur, so many days are all different. Yeah, that is correct too. So it should be considered.
All right. So thank you so much for having me and good evening from Germany. I try to share my screen. All right. Now you should see my screen.
We can see it, Jörg.
All right. Just a moment. All right. So I was asked by Vincent and Sharon to give some remarks on community action with a positive spotlight on Europe. So here we go. And I'm a kind of representative of the German Working Group for Air Hygiene, Deutsche Arbeitsgemeinschaft für Lufthygiene, called DAGE. So where we came from as started from different grassroots initiatives, and we gathered at End Coronavirus and were co-founders of the WHN. And now we are working together in Germany with different associations, mainly fighting for clean indoor air. Okay. You heard the talk of Spela, of one of our ambassadors already. Okay, and what we do some marketing for clean air and advocating for clean air and so on. So the question is, what is good in Germany or in Europe? So I posted this newspaper article with Vincent, and he said, "Well, this is really quite positive because there's mentioned that the countries in Germany have to implement an EU directive concerning wastewater surveillance and so on, and they still do it. So there's no result of the wastewater monitoring, but at least they monitor it. Okay, and we have as I said, an EU directive, and they established a dashboard where you can check out the EU countries concerning different pathogens in the wastewater, such as COVID, influenza A and B, and RSV or yeah, RSV virus. The data are quite nice shown, and you can check out different countries and uh, increase of the pathogen concentrations within wastewater yeah, for different time periods and how it's going on, just like now for the different EU countries. And you see here Germany on the far right side, and it's quite going up a bit in the winter time, like now. Oops. Another positive example is indoor CO2 map, which was initiated by Aurel Wünsch, and he coded an app for iPhones and Androids to collect CO2 data from different monitors such as ARNet and I think 5 to 6 other monitors, and you can donate your data, which means you can measure, for example, when you go shopping in a supermarket and you monitor the CO2 concentration within that supermarket. And if you have at least 5 measurements, you can, when you leave the supermarket, you can donate the data and upload it to that CO2 map. And they have, or we have up to now over 20,000 measurements. Okay, some examples. So you find the data on that GitHub server here. The measurements from last month, a median of about 800 ppm. Here you see in which countries most measurements are made. So the developed in Germany and Austria, followed by the States and UK and Switzerland, Netherlands, France, and some other countries. So feel free to donate more data via that map, the CO2 app and map. All right, some results. When you look to the far right side, you see that supermarkets and doctors have the highest CO2 concentrations, which indicates the worst indoor air quality. On the far left side, there are do-it-yourself shops, museums, and so on. They have a fairly good indoor air quality. And you see a kind of seasonal variation in different types of buildings. In summertime, the indoor air is fairly or is better than in the wintertime, which is not very astonishing. All right. So what is planned in the future and what took place already in the past? So there's a Geneva Health Forum initiative in Switzerland, and they organized already two indoor air quality conferences in cooperation with a European region branch of the World Health Organization. The first conference was held in September 2023 in Bern, Switzerland, and the second indoor air quality conference was held in Paris, France in 2025, next year. And you see on the bottom here that many initiatives and associations support that conferences. Okay, here are the conferences held already in 2023 and 2025 in Bern and Paris. And we have planned upcoming conferences in Rome in 2026, so next year, in Vienna end of the next year, and in Berlin in 2027. And all these associations work together already. And we use these conferences as kind of milestones to get more attention and more awareness for clean indoor air. And we are working on a WHO resolution for clean indoor air, which also should be promoted through these conferences. And to come to an end, there are some pictures of very new documentation about ski jumping in Europe. And you see our national team, and you see at least some masks on the faces, which because they have realized a mask could be a good way to protect themselves from getting ill, and they don't want to get ill. So, but I think there's still a way to go that all of the teams will use the mask. Okay, in that way, thank you so much, and good flight and all the best for 2027. And we work further together on clean air. Thank you so much.
Thank you.
Thank
Thank
you,
you so
Jorg.
much. Thank you so much, Jorg. I'm not sure if I'm still coming in wavy with the reception, or is it clear?
You're good.
You
You're
sound
clear.
good, Katie.
Okay. Sorry about the technical issues. We had a few today, but I did put the new and improved survey and follow-up form link. Most importantly, if you had any questions or wanted to join or just had feedback about the event, there's a quick and easy form, Google form you can fill out that I just posted there with the red diamond. And I would just like to thank everyone who was able to spend their time with us. Um, and we do have one of our partner members, DJ Carnivora, who is spinning some tracks in Europe, and we would love for you to hop over there for some fun. The link is in the chat, and that will be running for another hour and a half. So you could head over there. Um, Thank you so much, everybody. I hope you have a safe new year. Thank you.
Thank you.
Thanks, everybody.
Thanks, guys.
Thank you. Hope to see you around at some meetings. Sharon will have welcome meetings in January, and we always have our open meetings right here on WHN on our workspace on Slack.
Yep.
And there's also an open Zoom meeting with Frank on Fridays. So I hope you find a time to drop in and say hello. If you have any questions, I'm going to put my email in that is very easy to access, katie@nexi.edu. If you need anything, please do reach out. We will be editing this recording and we'll be uploading pieces of it to the WHN Global YouTube account. So if you're not already following or subscribed to our YouTube account, please go search for WHN Global to get notified of our new videos that get posted. Thank you.
Take care, everybody. Happy New
All
Year.
right. Thank you.
Happy New Year, everyone.
Happy New Year.
Happy New Year.